check, low, check, check, low, check, check, check on, low, low, check, check, low, check on, low, 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 check, check on, low, low, check, check, low, check, check on, low, check, check, low.
Check, check. Hello, hello, hello. 1, 2, 3, 4. Hello, check.
Low, check, check, low, low, check, check on, low, low, check, check on, low, 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 check, check on, low, low, check, check.
So, as you can see, sir has been a very fabulous speaker who is well known to all the endocrinology fraternity across India. So, I would request sir to please chair the session and start the proceedings.
Thank you so much for the generous words. Without much ado, let's start this session on pediatric endocrinology. And the first speaker is Dr. Asim Maldar. He'll be speaking on approach to a child with recurrent fractures. And he did his DNB from PD India Hospital. He works there as well. Recipient of ESI Yuvaratna Award, AR Sheth Awards, numerous of them. So without much ado, let's start.
Okay, so good morning, everyone. Welcome to the first session of the final day of SECon 2025. We have had quite, academic feast over the past 3 days. And without further ado, I just move on with my session. Approach to a child with recurrent fractures. So a single broken bone can be an accident. 2 broken bones can be coincidence, but recurrent fractures, they are a red flag in a child, and that needs to be decoded. So we'll go ahead as a case-based approach. How do we approach a child? I mean, there are too many things to discuss. I won't go into many details, but just an overview of things. So a patient, a child referred to us with a chief complaint of 3 upper limb fractures over the previous 2 years or so. How do we approach this? I mean, first, what I'll just like to say is we look at the history of fractures. We look at if there are any other systemic illnesses, systemic history regarding primary bone disorders, we go ahead with the investigations, lab investigations, X-rays, bone mineral density, if needed genetic testing and therapy. So this child, what are the uh, prevalence rates? So we know that at least half of the children will have at least one fracture till they reach the age of 18 years, and more than 20% will have more than one fractures. Boys are more prone to get fractures. The most common age is 11 to 15 years because of the growth spurt, adolescence, risk-taking behavior, sports, etc. And forearm fracture constitutes 50% of all the fragility fractures in a child. An important thing to understand is that only a minority of these children will have an underlying pathological cause, and it is our duty to find those children and treat them so that permanent skeletal deformity, growth impairment, or uh, reduced quality of life is actually prevented. So osteoporosis, I mean, fracture history, we look at the number of fractures, the type or why the fracture has occurred, where the fracture has occurred, and the other systemic history. So the number of fractures, even one vertebral compression fracture defined by a 20% height loss in the vertebra by Ganant's semi-quantitative classification can constitute osteoporosis, or a BMD Z-score which is below -2 along with a clinically significant history of long bone fractures, as you can see, more than equal to 2 below the age of 10 years or more than equal to 3 below the age of 19 years. But there are multiple caveats to this definition by International Society of Clinical Densitometry. They state that just a Z-score of less than better than -2 will not preclude the possibility of fracture, as there could be many conditions where the bone mineral density might be good, but still we should be going ahead with the evaluation of fracture history. And the clinical context matters. So this will be a repeating theme here. I mean, the fracture history, the systemic illness history, the bone mineral density, and the labs. So all of these things will go hand in hand to evaluate a child and to offer them a therapy. And if we are coming to the fracture history, an important history is about the low trauma fracture. So by definition, they say that any fracture outside of motor vehicular accident or a fall less than 10 feet. But the definition which has been again given in high-risk chronic illnesses is the one which is more sensitive, and we use it very commonly in our clinical practice. That is fall from a standing height at a speed of less than a walking speed. So this is more sensitive to diagnose osteoporosis. The second thing after the fragility is the magnitude, the type of fractures. So a major fracture, fragility fracture involving the vertebrae, involving the humerus or femur will carry more weightage as compared to the other fractures, and they will require less other clinically significant evidence to go ahead with the evaluation. And then we come to the underlying systemic illnesses. So this was a study which was from Doha, where they have actually shown that the most common underlying etiology for a recurrent fracture is nutritional, and Dr. Khadgawat sir will be talking about that. It will be a master class, of course. And then the most other common are medication, steroid-induced, rheumatological, autoinflammatory diseases, genetic, and endocrine. Now, if you have to approach a patient, how do we classify? We look at the genetic and non-genetic causes, and then we rule out the most common nutritional causes and then move ahead from there. So if we talk about those, we first look at whether there is a primary osteoporosis bone disorder, congenital bone fragility, or there is a bone fragility due to acute or chronic illnesses, and rule out rickets and non-accidental injuries. So non-accidental injury is something like a child abuse, which is a more politically correct term to use, is non-accidental considerations. And there will be some red flags, like inconsistent or changing history, delay in seeking medical help, multiple fractures in various stages of healing, associated with soft tissue injuries, and uncommon fractures. Now these require a very sensitive history taking, elaborate history taking, and a good documentation. Coming to now the genetic causes. So there are more than 300 monogenic disorders which can be associated with skeletal fragility or skeletal presentations. 30 or almost 10% of them can have severe skeletal manifestations. But the skeletal complications are neither the first nor the predominant manifestations in most of these diseases, except for osteogenesis imperfecta, hypophosphatasia, or osteoporosis pseudoglioma syndrome. So talking about osteogenesis imperfecta, a few lines. We know that it is one of the most commonly inherited bone fragility disorder due to mutations in the collagen 1 genes. And most common types are type 1 to 4, 2 being most fatal in the perinatal period, most severe and fatal in the perinatal period. And the variability of expression, even in the families, is usually seen. Other genetic causes, mutations in the ALPL gene, causing very low alkaline phosphatase levels and hypophosphatasia. An important thing to consider is the treatment is enzyme replacement therapy and not bisphosphonates. Osteoporosis pseudoglioma syndrome, LRP5 mutations, they usually present with congenital vision loss. LRP5 mutations are now considered one of the very common mutations for bone fragility, especially in adolescents and young adults. And multiple studies, even without this syndrome, have shown that there are LRP5 mutations. And then there is a diagnosis of exclusion, idiopathic juvenile osteoporosis with a peak onset around 8 to 12 years, which is often self-limited and child grows out of it. Then there are multiple systemic illnesses. I won't go into the details. There could be nutritional factors. There could be metabolic disorders. There could be other systemic illnesses like the endocrine diseases, the gastrointestinal disorders, the inflammatory conditions or rheumatological conditions. All of them by themselves can affect the bones, and their treatment in fact can also, like glucocorticoid therapy, can have an adverse impact on the bones. And like most common medication, we have seen the glucocorticoids, usually affecting the thoracic spine and presenting with spinal fractures. So again, just to reiterate, it is important to take the fracture history, the family history, and the medical history of a child. Look for the type of fractures, number of fractures, the fragility index in a fracture, what type of fractures, to determine how much evidence more we need to go ahead with evaluation. Look if we can find any other acute or chronic underlying illness. If not, look for any family history or bone disorder history and medical history. And again, an important thing to consider is the vitamin D intake, the physical activity, and sunlight exposure of the child. Other specific histories, we have already seen what could be the underlying conditions which can be associated here. Physical examination wise, of course, the anthropometry and charting of the height, weight, BMI on a growth chart becomes very, very important, not just during the diagnosis, but also during the follow-up. Looking at arm span to height ratio, upper limb, upper segment, lower segment ratio. So a high upper segment, lower segment ratio can point towards rickets, skeletal dysplasias, or congenital hypothyroidism. A lower upper segment, lower segment ratio can point towards a disease like Marfan's or hypogonadotrophic hypogonadism, spondyloepiphyseal dysplasias, etc. And important thing is to look for the other deformities, spine curvature, look for specific signs of underlying disease, again, bone disorders or other acute or chronic illnesses. So coming to our child, what did we gain from the history? All the fractures were low to moderate trauma, that is fall while riding a bicycle, fall from a sofa or while playing. No other positive history for an underlying bone disorder or a chronic or acute illness was there, and the child was not on any calcium or vitamin D supplement. So with this, now suppose if we have had some underlying chronic history, we would have evaluated or gone ahead with that evaluation for blood tests, etc. Now with this, what do we do? I mean, like I said, there is a puzzle. One of the thing is fracture history, the other is the other chronic illness history. The third is to get a basic set of lab investigations and a bone mineral density with X-rays, of course. So the basic set of lab investigations will always include calcium, albumin, phosphorus, vitamin D, alkaline phosphatase, the bone parameters, creatinine, electrolytes, a complete blood count, thyroid function test, liver function test, urine routine analysis with an HbA1c. And depending on the other underlying conditions, we can go ahead and ask for multiple other tests as well to look at idiopathic hypercalciuria, to look at renal tubular acidosis, a celiac disease, specific endocrinological disorders, or rheumatological inflammatory disorders. What I would like to reiterate here is that two things, that renal tubular acidosis and celiac disease, they are two diseases which cannot have any apparent symptomatology or presentation, but can just present with maybe short stature, failure to thrive, or even recurrent fractures. So these are the two etiologies that we should be keeping in mind. So plain X-ray can help us with various things to look at the fracture sites. Lateral X-ray or VFA through the DEXA can help to look at vertebral morphometry. Assessment of bone quality, specific disease like rickets, hyperparathyroidism, or Paget disease can be diagnosed via X-ray. And a whole skeletal survey can be done in patients with non-accident injury or skeletal dysplasias. And X-rays can also help us to determine the bone age. Bone mineral density, I mean, this can take a whole class. The bone mineral density in pediatric population. The bone mineral density, like in adults, is not something that is diagnostic. It is, like I said, just one of the pieces of the puzzle. So if you have a poor bone density, yes, it will add on that we can go ahead and evaluate further or even treat the patient. But if not, even in conditions like rickets or even in a short stature, the apparent bone density can be very, very poor. So these are some of the caveats that we have to take into consideration. And at follow-up, the bone mineral density can provide an important clue whether we should wait, observe, or go ahead with the evaluation and treatment. An important thing in children to differentiate is that we look at total body less head or lumbar spine as per the ISCD guidelines. Other sites like distal forearm, proximal hip may be used if we need some additional data, or the lumbar spine and TBLH cannot be used in this condition. To adjust for short stature, there is an apparent bone mineral density which can be used, which converts the aerial BMD into volumetric BMD, and height Z adjusted BMD Z scores. So this is the Molgard approach which we usually use in our practice. So genetic analysis, again, if you come to our case, there was no other apparent thing. And if the bone mineral density also would come down, we could go ahead with a genetic analysis of whole exome sequencing. If there is some specific illness pointing towards maybe skeletal fragility, osteogenesis imperfecta, etc., a clinical exome sequences can be planned. Again, genetic analysis is something which we can go into much detail and discuss, which is actually outside the scope of the talk today. So these are one of most common genes which are there, osteogenesis imperfecta, and then primary osteoporosis with other distinguishing features can have other monogenic causes which can be diagnosed through whole exome evaluation. So coming to our child, anemia, nutritional anemia was present with the low hemoglobin and low PCV, slightly low alkaline phosphatase levels with insufficient vitamin D levels. DEXA scan showed a Z score of -2.7, and further evaluation from the secondary lab tests showed a positive celiac antibody screening, which was again confirmed with a histopathology, MARCH3B. And we know that the children with celiac disease, like I had said, that this is one of the conditions which can be silent and present with short stature only or failure to thrive and fractures. These children have almost 2 times increased risk of fractures because of malabsorption of calcium, vitamin D, other nutrients. Underlying chronic inflammatory state can have an impact on the rank ligand and OPG axis, etc. So usually the more important question now with regards to therapy comes is, which patients do we offer specific anti-osteoporosis therapy? So an important thing is that we classify the children and look at whether there is a potential in their skeleton to heal spontaneously or not, a high potential or a low potential. As compared to adults, a child's skeleton can recover very fast provided that the underlying condition is abated, taken care of, and there is a potential to heal, that is, there is time. If the child is younger, the more the better the healing would be. So if the patient has all of these things, like a fracture or a low trauma bone fracture, suppose if the patient does not have And there is an underlying condition which we already know, like a primary osteoporosis, DMD, or poorly controlled underlying disease, or a patient is on glucocorticoid management, it would be prudent to just follow up the patient, monitor BMD every year, and an X-ray. If these things are present, we look at the child's ability or the potential to heal spontaneously, which would show that if there are transient risk factors like less than 3 months of steroids, short-term immobilization or well-controlled underlying disease, a younger age, or milder collapse or lower grade of fractures, all of these would point towards more potential to heal on their own, and we continue monitoring, like doing an annual spine imaging and a BMD, and looking at the loss or change in BMD to take us forward. Now suppose if there is a loss of BMD, or if there are any other factors like a new fracture, loss of end plate parallelism, anterior cortical buckling, or a new long bone fracture, then go ahead to the left side, again evaluate the potential. If the potential to heal by the self is low, we go ahead with anti-osteoporosis management or bisphosphonate therapy. General management would include treating the underlying cause, the nutritional support, physical activity, depending on the patient's child's condition. We all know that the weight-bearing exercises have a more impact rather than just conditioning or cardiac exercises. And safety measures, fall prevention is one of the most important things. Coming to bisphosphonate therapy, again, we go ahead, evaluate, look at that there is a fracture, look at the ISCD guidelines, and once we have decided that the child has low potential to heal, we go ahead with the bisphosphonate therapy. And on follow-up, we look at all of these parameters: absence of new vertebral fractures, reshaping of the previous vertebral fractures, no back pain, no new long bone fractures, and improvement in the bone mineral density. And if that is the case, we go ahead and reduce the dose of bisphosphonate therapy and maintain the child on a bisphosphonate therapy if there is primary osteoporosis until there is epiphyseal fusion, secondary osteoporosis till the risk factors last. So this is something that we treat. Now coming to just a few things about the bisphosphonate therapy, an important thing even in adults we look at is the fitness. So we want sufficient vitamin D levels, we want sufficient renal reserve, eucalcemia and euphosphatemia. These are the various regimes which have been talked about as far as IV bisphosphonate therapy is concerned. Very commonly pamidronate was used, but nowadays it is changing to more of zoledronic acid therapy because single dose, less quickly given, it is easier to administer. Side effects, first infusion adverse events we know, especially in people with hypocalcemia or hypovitaminosis D. An important aspect is to consider adrenal insufficiency, which can be precipitated as a first infusion reaction, especially in children with chronic glucocorticoid therapy, even though they may be on supraphysiological doses. The other side effects we are well aware of. There are a few debates that can happen, which is better, IV or oral bisphosphonate. The answer is not straightforward. I mean, both of them have shown an improvement in the BMD. However, the fracture healing rates, improvement in the vertebral morphology, and change in the bone turnover markers are better with IV. So IV are the first choice. Role of denosumab, it's a monoclonal antibody against rank ligand. Not specifically used in children because once you discontinue or the effect wears off, there is a rebound, and in children there is severe hypercalcemia which is seen. So it has been used in OI type 1 to 4 and type 6 specifically, and there are some reports which say that denosumab alternating with zoledronic acid gives better results. There is a phase 2 trial with just finished. Yes, sir. Phase 2 trial with DMD, which is going on with denosumab. And again, anabolic agents, a good thing is that teriparatide has, that black box warning has now been removed for osteosarcoma. However, there is not much data in children. And again, a phase 2 trial with anti-sclerostin antibody is going on in patients with osteogenesis imperfecta. So we'll wait for more data with regards to these therapies. So coming to our case, treatment, simple celiac disease treatment. There was improvement in the celiac serology, improvements in the BMD, no fractures, and asymptomatic younger sibling was also diagnosed with celiac you so much for everyone's patient listening.
Thank you so much for the great lecture. We'll have question at the end. It was a very well worked up case. And without much ado, the next speaker, Professor Rajesh Khadgawar from AIMS, with his DM from LGPGI, 211 publications, 32 best paper awards. Without much
alone. And thank you all. You came on Sunday night, Sunday morning early. So one of the difficult area of pediatric endocrinology is resistant rickets. We know nutritional rickets. Everybody must have seen many, many cases of nutritional rickets, and you give calcium, vitamin D, and you can see here there is there is there is clear healing in rickets, and Indian Academy of Pediatrics says that you give 3000 units daily for 12 weeks, although this large dose, and we have shown in one RCT that even if it's a very small amount of vitamin D, we gave a single dose of 90,000 and showed similar healing with the Thatcher's score remaining same even with the single dose. However, when we classify rickets, there are many systems of classification, and this is one of the most traditionally and most commonly used system of classification of rickets, where nutritional rickets, which is altogether a different category, and then we have non-nutritional rickets. It could be secondary to renal phosphate tubulopathies, vitamin D resistant rickets, and then we have a rare variety of vitamin D dependent rickets, could be type 1, type 1A, type 1B, and type 2. These are dependent on vitamin D because nothing else would heal. And how do we define? There is no consensus on when to call resistant rickets. All those children who do not respond to standard therapy with calcium vitamin D with a adequate period of 12 weeks, and after 12 weeks if repeat X-ray there is no complete healing, although there may be problem with the malabsorption, problem may be compliance, but if these problems are removed and if we assess after 12 weeks, if no healing, this is resistant rickets. And commonest cause of resistant rickets is hypophosphatemic rickets. So hypophosphatemia, together phosphate with vitamin D is required for mineralization of bones. It's tightly controlled by PTH and FGF23, and to some extent vitamin D also plays important role in normalization of phosphate, but essentially this is with PTH causing hypophosphaturia. Whenever phosphate increases, PTH increases. Whenever FGF23 increases, the more and more phosphate goes down. So this is tightly regulated by these two hormones, and it's very rare in a normal human physiology to have hypophosphatemia because what we eat, diet adequately provides phosphates. But if there is phosphate deficiency, can lead to rickets, and two special situations where without any much pathology we see hypophosphatemia and hypophosphatemic rickets is premature infants and infants because of high requirement of phosphates during that period for the rapid building of the bone. And I didn't do anything. And during this period, if they are totally on the breast milk, may not get that phosphate, so they are at high risk. And we have seen in past excessive use of antacid can also lead to that. Hypophosphatemic rickets is most common type of non-azotemic refractory rickets, and most of the time this is misdiagnosed as nutritional or metaphyseal dysplasia or physiological bowing, and most of the cases of hypophosphatemic rickets are inherited. Of these all inherited causes, isolated phosphate deficiency or isolated hypophosphatemia is the major cause of hyperphosphatemic rickets, although we can see hypophosphatemia as a part of generalized proximal tubular dysfunction, what we call as primary or secondary Fanconi syndrome. In adults, we see a lot of cases with tumor-induced osteomalacia, which is almost not well described in pediatric age group. So what are different causes of hypophosphatemia? I have marked XLHR in red because this is the cases we usually see in the clinical practice. although this could be autosomal dominant, recessive, it could be a part of polycystic fibrous dysplasia, neurocutaneous syndrome, and hereditary hypophosphatemic rickets along with hypercalciuria, so there is some difference in management. Renal tubular disorders can also present with hypophosphatemia. If it's associated with acidosis alone, it could be a part of distal renal tubular acidosis, or if with the gross malabsorption of other filtrate like glucose, amino acids, dyselectrolytes. So these comprise primary and secondary Fanconi syndrome, and if associated with the hypercalciuria, it becomes dense disease. Loess syndrome or oculocerebrorenal syndrome and ifosfamide therapy are still they can cause, but actually not very well described in that ifosfamide, which is a congenital cyclophosphamide, is more likely to cause neurological toxicity and come into picture because of that, but if still continued can lead to renal tubular acidosis. So basic defect in X-linked hypophosphatemic rickets is there is impaired reabsorption of the phosphate. Normally 85% of phosphate is reabsorbed in the proximal tubule, but in these cases they are not reabsorbed because of the loss of function mutation of the PAX. PAX is the gene which metabolizes FGF23. So if there is mutation of PAX, FGF23 will not be metabolized, levels will increase and will result in phosphaturia. And there could be familial transmission in 15 to 20% of the cases. And this is picture of one of family under treatment with us, where you can see the mother operated for genu valgum, and then both sons, they were affected with rickets and found to have hypophosphatemic rickets. And then we have other varieties which are again little bit uncommon, could be autosomal dominant, recessive, and then we have other causes, neurocutaneous syndrome, which also secretes FGF23. So just a glimpse of how do they cause. This is the normal metabolism of FGF23. So metabolized by PAX, and then it level comes down. So if there is mutation in PAX, it will not be metabolized. If there is mutation in FGF23, then there is abnormal abnormal FGF23 which is resistant to the action of PAX, or there may be mesenchymal tumor which is producing extra amount of FGF23. However, there are FGF23 independent causes of hypophosphatemia. Most common of FGF23 independent causes are hyperparathyroidism, vitamin D deficiency, malabsorption. There are few genetic causes also, but these are again exceedingly rare in clinical practice. Could be a part of renal tubular acidosis as well, but most of these causes present quite early with very severe manifestations. Clinical features of hypophosphatemic rickets are not usually different from the nutritional rickets. Apart from the few features, there is no muscular weakness, fractures are not common, dental abnormality, hearing defects, which is not usual part of the nutritional rickets, are there. Ricketic rosary, deformity of upper limb, active rickets of spine, pelvis, tetany, convulsion. These are the features which are more seen in calcipenic or nutritional rickets, but essentially missing from the hypophosphatemic. And severity of bone disease in hypophosphatemia does not correlate well with degree of hypophosphatemia or FGF23 level. Radiologically, there is hardly any difference. By seeing X-ray, you cannot find out whether it's hypophosphatemic or it's a nutritional rickets. And most important thing is to keep in mind that there are mimickers with the rickets. So this is case of spondyloepiphyseal dysplasia presenting clinically. Absolutely, you cannot differentiate from the other forms of rickets, and there are both diaphysis and metaphysis changes. And in cases of metaphyseal rickets, you may see predominant changes in epiphysis, sometime appearing so irregular that it may give confusion of hypophosphatemic rickets also. But these two differentials should be kept in mind, and then move ahead with investigations are essentially not hugely different. Hypophosphatemia could be part of that, and we all know that how to calculate TMP GFR. Yesterday we had a wonderful lecture on TMP GFR, which is the main investigation of workup of hypophosphatemic rickets. And this is very complex formula. When we were doing endocrinology learning at that time, we need to calculate this TMP GFR, and just to note that TMP-GFR is age-specific and sex-specific. There cannot be a single value cutoff, but forget about everything. Now what we have is these e-calculators. Even if we ask a resident, we tell them that at least remember formula. So in exam, you can respond what is the formula of TMP-GFR, but hardly anybody remembers that. And whenever you ask them for TMP-GFR, within seconds reports are there. These are the various TMP-GFR, not only single TMP-GFR, they will give many other values, but difficult to understand once what we need is TMP-GFR only. A word about FGF23 in diagnosis of hypophosphatemic rickets. It's very fascinating to measure FGF23, but there is hardly any importance. Transporting sample of FGF23 is difficult. It's a not regular assay, not well standardized. It's costly, and only thing it does is differentiate between FGF23 dependent or independent causes. Otherwise, it doesn't help anywhere in the treatment and prognosis. And most important is we do not know what is normal FGF23. But however, whatever kit ranges are there, we compare to that and we say FGF23 is elevated or not. Then we have many pre-analytic issues with measurement of FGF23, and there is a poor agreement between these assays. So it's again not very good investigation. It's not an easy investigation to interpret, but automatically whenever rickets come, everybody, we just go for tick the FGF23 and we think that it will help in that. And another problem is there is a huge intra-individual variation. There is a diurnal variation. FGF23 in the morning, FGF23 in the evening could be usually so different that it may not make interpretation of FGF23 or dependent or independent. The less common form of hypophosphatemic rickets is if it's associated with a renal tubular acidosis. It could be DRTA, it could be proximal renal tubular acidosis, it could be a part of dense disease, and then we have other. This is another really difficult portion of pediatric endocrinology, how to evaluate. This is really busy slide, but I wanted to show all these 4 steps. These steps doesn't mean that we do stepwise. We do all in steps just to save time. We do all steps. So you calculate plasma anion gap, not difficult. It's normal in most of the cases of renal tubular acidosis. Then calculate urinary anion gap to find out whether there is an extra-renal or renal cause of hypophosphatemia. TTKG or transtubular potassium gradient, although to here it looks like that we have to enter into the nephron and then measure. It's not that. It's a very simple investigation. You can measure, and this will clearly tell whether it's a potassium loss is renal or extra-renal. Once we have decided, then go for determination of urinary pH. Presence of acidosis and pH is more than 5.4 establishes your diagnosis. Need not to do any other test for diagnosis. If it's less than 5.4 and still we are suspicious of renal tubular acidosis, then we can go for either furosemide, fludrocortisone test, or older version. Older people still might be continuing with ammonium chloride challenge test, as I am doing still with ammonium chloride, because we have done from our residency ammonium chloride, and our residents do furosemide, fludrocortisone test. And once we have ruled out distal renal tubular acidosis, then there is a scope of bicarbonate loading test just to rule out proximal renal tubular acidosis, which is again difficult to interpret. One of the major investigation is furosemide fludrocortisone test, where we give furosemide and fludrocortisone and then we check urinary pH whether they acidify it or not. And once we have gone through all these tests, then we go for the specific investigation to find out the cause of proximal renal tubular acidosis, 24-hour urinary beta-2 microglobulin, urinary aminoacidogram, glycosuria, hypercalciuria, nephrocalcinosis. And once we have done with all investigation, then we need to go to find out what is the cause of proximal renal tubular acidosis. Maybe genetic workup may help here. Just to tell about what's our experience of hypophosphatemic rickets. Over last 20 years, we have seen 36 cases of hypophosphatemic rickets after excluding nutritional rickets and skeletal dysplasia. And those patients who have not followed up with more than 1 year, we have ruled out. Short stature and proximal myopathy were two presenting features. Skeletal deformities, especially genu valgum, genu varum, was seen in 86% of the cases, while pseudofracture in 30%. 13% had first degree relative and consanguinity. These are the different clinical diagnosis we thought of that. And just to compare their radiological features, you can see that renal tubular acidosis is usually different. The height SDS is minus 4.2 as compared to them, and all other parameters. And most important thing is they were diagnosed at 11.5 years. That clearly shows that we have missed them for many years before they are diagnosed. And then we went ahead and did genetic analysis. So 70% of cases we could finalize what were the mutations in these cases. So if we put all these in an algorithm, how to investigate of resistant rickets. So these are the basic investigations, like radiological rickets should be there, hypophosphatemia, raised alkaline phosphatase for age, normal renal function and liver functions. Radiological changes may be mimicking, but if biochemistry is normal, we rule out all causes related to skeletal dysplasia. Then we can measure vitamin D and PTH. Very high PTH, vitamin D level low, goes for vitamin D deficiency or nutritional rickets. Straight away we can go for treatment, not much is required. If it's a normal or borderline PTH, borderline normal or borderline high PTH associated with a normal or high vitamin D, although there is a lot of overlap between these two conditions, even if a patient with hypophosphatic may have vitamin D deficiency, because 90% of our population is vitamin D deficient. Then one category which moves out is vitamin D dependent, type 1, type 2, and otherwise also they are extremely rare. Over the years we have seen just couple of these cases. If TMP GFR low for age, and here comes the role of FGF23. Would not like to go in detail of that, just indicate that whether it's a hypophosphatemia alone or not. Then measure for glycosuria, proteinuria, acidosis, hypercalciuria. If all are negative, TMP GFR is low, that clearly indicates XLH, autosomal dominant or resistant type of rickets. If acidosis is there, rest all are negative, it's a distal renal tubular acidosis. If acidosis is negative but rest all, glycosuria, proteinuria, hypercalciuria is there, it goes in favor of dense disease, or hypercalciuria and rest are positive, no hypercalciuria, this primary or secondary renal, proximal renal tubular acidosis can be there. So just to summarize, commonest cause still is nutritional rickets. And what we are doing routinely is, when we start investigation for hypophosphatemic rickets, at the same time we start treatment for nutritional rickets. By the time they complete all investigation, that 4 or 6 weeks is already there. So you can, with surety, you can say that this is not nutritional rickets. So once you see, start treatment, the best thing which indicates the resistant rickets is there is no healing with calcium and vitamin D. And once these investigations are there, then we can start treatment. Treatment is very gratifying. This is our serial x-rays of one of patients, where you can see that there is clear rickets and healed over the time. This is another patient, one of the severest rickets, just finishing, sir. One of the severest rickets, and within 6 months there is complete healing with the resistant rickets. Now leaving with you very distressing pictures of one of our patient. This is 7-year-old, multiple deformities, not able to walk, skin lesions, and you can appreciate that these are the skin lesions, and these skin lesions are producing FGF23. And when we did X-ray, one of our senior resident started counting fractures. He could count only 70 fractures, and there were more fractures beyond that. You can see everywhere there were fractures. So severe FGF23, and when we did bone scan, we got published this picture also, the Indian dance position. and there were multiple uptakes, clearly suggestive of super scan. So these are unfortunate cases. We tried to do laser ablation of skin, these skin lesion. We reached to a great success. We thought that we will be able to that, and by the time only one lesion left, child died of pneumonia, which could be part of associated increased risk of infection with the hypophosphatic rickets. Ladies and gentlemen, thank you very much for your patience-full hearing, and thank you, Chairperson, for being here.
Thank you so much for that elegant lecture and finishing well in time. Thank you so much. We'll have questions at the end.
I
So,
saved time.
thank you so much. So the next question, the next rather topic is on childhood obesity. Dr. Khushbu Agarwal to present her deliberation. She works at CMC Bellore. She's a member of task force of ESI, awarded best researcher by Tamil Nadu MD University, winner of ISBMI grant, and multiple publications. Over to you.
Thank you, sir, for such a kind introduction. So from the bone management, now we'll go to the childhood obesity. My topic is clinical approach. So this is a 17-year-old obese girl who came to our clinic. Her BMI was 62 kilogram per meter square. She was referred to us for obesity. She had difficulty in walking, and she also had recently diagnosed diabetes mellitus. So my first question is it important to know about childhood obesity? Are we concerned about it? So unfortunately, the answer is yes. So this is the WHO 2007 growth chart and CDC growth reference. And according to 2024 World Obesity Atlas, 9% of prevalent obesity is in children in less than 20 years of age. And in India, estimated 83 million children are estimated to be obese. This is another study in NFHS 5 data, which showed that prevalence in preschool children was 3.4%, and in school-going children, obesity extended up to 17.6%. In other words, 1 in 5 children is obese in school-going children. This is another distressing data. You can see from 1975 to 2016, from a time where there was not a single child who was obese, now we have increasing prevalence of obesity both in South Asia and Southeast Asia. So yes, we are very, very concerned, and similar prevalences have also been shown in multiple studies across our country as well. So a brief history we took. The girl was an intelligent girl, and she gave us underestimated diet, and her initial diet evaluation was 2,000 kilocalories. It was mainly carbohydrate South Indian diet. I'll come back to this. She was a third-degree consanguineous marriage second born child. Why is family history important? Family history is important. This was the first study that actually showed that there is a very remarkable correlation in body mass in monozygotic and dizygotic twins. So why is it that the prevalence of obesity is increasing in our country? So the reasons actually go back to the thrifty gene phenotype and the fuel-mediated teratogenesis, the same reasons why diabetes is increasing. And now, unfortunately, because of this, we have the distinct award of being the capital of undernutrition as well as overnutrition, GDM, as well as diabetes. We also have enough data to show that colonialism, specifically the areas that were affected by the colonialism, the separation, these are the areas, even in our, you can see the states that were impacted by the partition are the ones with higher prevalence of obesity. Of course, everybody knows about this 2004 Dr. Yagnik's paper, Thin Fat Indians. Not just thin fat Indians, thin fat babies. This was his study in which he showed that right from the babies, this is a comparison of Indian baby and a Caucasian baby. We have definitely got a less muscle mass and more fat right in the visceral adiposity, which eventually translates into adult obesity as well. There are multiple mechanisms for this, right from the maternal nutrition to lack of breastfeeding and other inflammatory reasons. So this is a reason. But however, this is not enough. We also have this eventually gets translated into childhood obesity due to other factors, including socioeconomic factors, environmental factors, behavioral factors, and it's definitely associated with the cardiometabolic disease. So the risk factors in childhood obesity include energy-dense food, dairy products, habit of skipping breakfast, multiple comorbid conditions in which children may refuse to eat nutritious food. Then we have socioeconomic factors, parental education, parental weight, of course, plays a role. Sleep, definitely a big role. Maternal factors, definitely mother's BMI and history of GDM has a role to play. Then we have exercise, all these entrance exams, and the pressure right from third, fourth standard definitely has a big role to play, and sleep. Coming back to a patient, this was the child. She had a height of 146 centimeters. She had lost quite a bit of height because of genoverum, and the BMI was 62 kilogram per meter square with a waist circumference of 140 centimeter. She had a grade 4 acanthosis nigricans. Rest of the general and systemic examination was almost normal. This is the X-ray of her feet. So basics first, what is the diagnosis of obesity in childhood? So this is the IAP growth chart in males and females from 2015, Khadilkar's chart, and these are the BMI specific plots in which you have to plot to make the diagnosis. These are the definitions. For 5 to 18, BMI more than 85th to 95th percentile is overweight, and more than 95th percentile is obesity. And in children below 5 years of age, we take weight for height or length more than 97th percentile to be overweight and more than 99.9 percentile to be obese. We have class 1, class 2 and class 3, which is BMI more than 95, more than 120% and more than 140% of the 95th percentile that can be done. So coming back to our patient, she was born to a third degree consanguineous marriage. Her birth weight was 3.5 kilograms. Then she was first evaluated for excessive weight gain at the age of 7 months, and her Cushing's workup was negative. And 5th year, she started developing varus deformity. She had, however, other normal developmental milestones. She had menarche at 15 years, but they were irregular cycles. And at 17 years, eventually she had diabetes, was started on oral anti-diabetic drugs, and as expected, she had depressive symptoms and low self-esteem. So how to evaluate for the cause of childhood obesity? So this is a Lancet paper, and these are all the complications that you should be looking at, right from the neurological, dental, cardiovascular, respiratory, endocrine, musculoskeletal, renal, gastrointestinal, and skin. Your examination should involve assessment of cause of obesity. You have to look at the root cause. Is it due to slow metabolism? This word is thrown around a lot. Doesn't really mean much. You have to look at the food habits. What are the cultural habits, physical hunger, mental health issues, poor protein intake, timing, eating timing, or is it due to decreased physical activity? And then, of course, all of us do evaluate for the metabolic part of obesity. We also have to evaluate for the mechanical part of obesity as well as the psychological aspect of obesity, which are equally important. As a child, it is very, very important that, of course, the history can give a clue to a lot of other secondary causes of obesity. You should ask for prenatal and birth history. You should ask for general medical history, developmental history, history of breastfeeding. There are enough studies to show that adequate breastfeeding is associated with decreased obesity in adulthood as well as in adolescence. You have to ask about growth and weight growth trajectories. If any other previous treatment has been done, what are the dieting and exercise behaviors? To ask about ethnicity, unfortunately, we are the high-risk group. You have to ask about stressors at home. You have to ask about parental relationships, employment. Is the child supervised or not? Extremely important in today's world. You have to ask about family income, and you have to ask about school behavior as well. I'm sorry, there's a typing mistake over here. Have to ask about attendance. You have to ask about if she's having, or she or he is having any learning difficulties, any behavioral problems. What are the hobbies? Especially in adolescence, you should also look at the substance abuse, tobacco, alcohol, or any other recreational drug. Just to recap, these are the complications that can happen, and please evaluate for all, especially if it's an adolescent. You should also look at the body dissatisfaction and low self-esteem and disordered eatings, and all of them also need evaluation and adequate addressing. So what are the factors that actually affect the obesity in children and adolescents? So in addition to the factors that we all already discussed, feeding practices, the culture, and support from the peers, the stigma, all of this also have a big role to play. And a lot of these, there's an increasing prevalence because of other lack of physical activity and lack of playgrounds to actually play. So all of that actually plays a role. So back to a patient. So you can see that she had dyslipidemia. She had poorly controlled diabetes. Basic evaluation, because she really did not have any syndromic features. So we just did a Cushing's evaluation and a hypothyroid evaluation, which was normal. Because of a genovarum, we wanted to rule out any associated rickets, and that part was also pretty much normal. So she had grade 3 fatty liver. Do you want to do any other tests? Does this child warrant any other evaluation for the cause? So yes, it's a genetic disease. We have monogenic disease and we have polygenic disease as well. And the differentiating factors can be that it's a single nutrition. If you will have family history which is very, very strong with the similar symptoms, then it will usually point to monogenic. However, polygenic is a lot more common. And what are the clinical features with which genetic and syndromic obesities they can present? They can present early onset, that is less than 10 years. They can present with disorders of eating behavior, lack of satiety, foraging, and obsessions with food. They can difficulty in tolerating food restrictions. Just to recapitulate, these are some syndromes. You already know all of this. They have other syndromic features like Prader-Willi will have eye features, hypogonadism, scoliosis, dysmorphia, which will make these diagnoses a lot more easier. Bardet-Biedl will have retinitis pigmentosa, renal problems. Then there are intellectual and developmental delay problems in other syndromic features. But I really want to emphasize over here, this forms a very, very small part of evaluation. So genetic obesity, we have syndromic obesity in which we have Prader-Willi and Bardet-Biedl syndrome, which do come with other neurodevelopmental issues and craniofacial anomalies. And then we have non-syndromic monogenic obesity, which is also equally important. And these involve mutations in leptin melanocortin receptor pathway. So this girl, she was MC4R mutation positive, and it's a autosomal dominant and recessive, both is there, and it's the most common part of mutation. So while it's a small part of childhood obesity, I wanted to emphasize over here that in our study we have seen that it was found in 16% of the patients, which is a big number. And they can have other features. Sometimes they can have retinitis pigmentosa, consanguinity that is pointing towards the diagnosis. Sometimes they may not have any of this, which is very, very important to make the diagnosis. So when to evaluate for childhood obesity? So this is from the ESI guidelines. So if the child has obesity less than 10 years of age, or has family history of consanguinity or diabetes, hyperphagia, developmental visual or hearing defects, macrocephaly, all of these features if present, you should evaluate the patient for a genetic cause of obesity as well. So the big question, how do we manage? So the best thing that you can do is recognize your own limitations. You cannot do everything. As intelligent as we may be, we need a team. And endocrinologist, so you should work with a team, and you should have a nutritionist, physiotherapist, and a mental health expert guiding you on the management along with you. And if you need, you can actually ask for a gastroenterologist or a respiratory physician or an orthopedic surgeon as and when required. So unlike our guidelines, which focus a lot more on drugs, IAP guidelines focus a lot more on habits. This is very, very interesting. So these are the guidelines, what they say. So they say that the child should be encouraged to be physically more active, and should not spend more than 2 hours on the screen. So the child copies your parents. So we have to emphasize that parents also develop healthy habits. So if the parents are active, then child will follow the same. So you really cannot be on your screen for 8 hours a day and then expect the child to go to the park. Okay, should not take sugary beverages, that is kind of expected. But more importantly over here, that please look at this part. You should teach, I am a very strong advocate of this. Cooking and taxes should be part of the school curriculum. You should teach every single child should know how to cook. You should consume homemade food, and you should not, you should actually eat together. These are very, very small things, but actually the most important things. You parents have to set the example. The ball is in parents' court. Children are going to learn when they are going to learn, but we have to them. Please don't shame them. Please don't insult them. And very importantly, please don't use food as a bribe or an award for a job well done or marks. If the child is getting first, today I'm going to treat you with a pizza. This association of certain kinds of food with rewards should not be done. They are the primary basis of how in later life they form the basis of all the eating disorders. Regular timings, regular snacking should be emphasized. You should emphasize on adequate amount of water and adequate sleep. Of course, our job is to talk about diet. These are the various types of diet that are available. Any guesses as to which is the best type of diet? Which is the best diet that you can give a patient? Thank you. Yes, the answer is the diet that the patient can follow is the best diet. Please don't give any fancy diets that the patient cannot follow. Don't give expensive diets. Don't have unrealistic expectations. This is a very, very nice table, and this is a nice figure that I actually use in my own clinic. Divide the plate into 3. 1/3 should be starchy vegetables, 1/3 should be dairy, meat or dal if the patient is vegetarian, 1 part should be leafy vegetables. Emphasize on increased protein in every meal with decreased carbohydrates. 3 meals and 3 minor meals, it's extremely, extremely important. The diet should be appropriate, accurate. It should be, most importantly, it should be affordable. I cannot tell you the number of times the patients have come to me that they cannot follow the diet because it's expensive. Please don't give chia seeds and avocado if your patient cannot afford that. So the second part is, of course, exercise. Child should be active, but as you saw this patient, you really cannot give up. You cannot expect that child to run a marathon right in the beginning. Please give a hierarchical exercise plan. You should start with stretching. As and when the child can walk, incorporate balance exercises in aerobics. And once everything is better, then probably resistance training can be incorporated. This is actually the most important part of obesity management. Not just a child, but you are going to fail when you are trying to lose weight. The key is not to lose hope. Your job as a doctor is to recognize why a child is or a patient is failing, try to motivate them, and tackling the barriers. They are like, I cannot follow the diet. So what is the problem in following the diet? I followed the diet, I lost weight and I gained it back. Please try to address the problem, the dissatisfaction. They may have unrealistic expectations. So you have to tackle that, and addressing them is actually the most important part as far as the weight management is concerned. Of course, pharmacotherapy is there. These are the drugs that over a period of time have been approved for children. More importantly, GLP-1s are approved for age above 12. Recently, semaglutide, injectable semaglutide has gotten approval for obesity. Setmelanotide is for genetic obesity, POMC, PCSK, and leptin mutations. We also have phentermine, topiramate, but they have to be given only for a very short period of time. You really cannot give. So that's why, as far as children are concerned, the previous 3 parts, the diet, CBT, exercise, are the major management. For the other parts, the other drugs are there for other genetics, this thing. Once the child has attained puberty, bariatric surgery is an option, but please ensure that there is no psychiatric illness and they have a stable family unit to take care of the patient. There are other various types of bariatric surgery with multiple complications all of us are already aware about. And so the management majorly involves behavioral intervention with diet, physical activity, and sleep hygiene. Then, of course, we can use the help of pharmacotherapy and bariatric surgery and on when required. So I would just like to conclude, please look at the patient, just don't look at the one aspect, treat it properly, and that's how you will get success in this management. Thank you.
Much for that great lecture and finishing on time. May I call the speakers on stage to address any questions? Dr. Khadgawat, Dr. Halder. So maybe a question per speaker, a pressing question if any.
Hello. Should we not, question to Khushbu, should we not start obesity education in school? Because we don't have sports period nowadays, children don't play in the school, so awareness should start from childhood and from the school only, no? So there should be some curriculum in the chapter on this. Yeah.
Sir, I would like to answer this in two ways. The child spends less than 6 hours in school. Less 18 hours is at home. So the responsibility is more with us than at the school first. Secondly, yes, as a society, we should definitely advocate that fast food should not be available in school. They should have, even if they want to have snacks, they should have more of home-cooked food that is available. Probably, tuition should be banned till 8th standard. They should not be allowed coachings and everything, and they should, like, compulsory physical education, all of this should be a part of it. But I'll tell you something, children follow parents. So if you're pressurizing your child to get good marks, and then you're angry that the child is gaining weight, I mean, at the end of the day, it will not work. Yes.
Children grasp more from the school than from both from parents and school.
Yes,
but
yes. And also cooking, sir. It's a gender neutral activity, and just like you're teaching maths and science in school, cooking should be a part. Like, it should be emphasized on, because when the emphasis is on parents, it's kind of ignored. So I definitely, it should be a part of school.
Government should create parks, cycle lanes, bicycle lanes. So these are not there. So children say, where should we play? We are talking about playing and outdoor activities, but spaces are limited, no? And everywhere you have to pay for it. Now the children are going for turf, cricket, football, and other things. They are paying for that. So not all persons can pay, you know.
Midday school meals, there should be ideal meals so that children can follow that at home.
So midday school meals are usually like, they are there to encourage children for schooling, but I'm not sure how much of us, like, how nutritionally appropriate they are. Like,
that should be there.
Yes.
Should be there, and especially the school canteens.
Yes.
It should not be allowed to sell.
And the advertisement should not be there till 10 o'clock. All of these Coke and all of these chips and all of these fancy item ads should not be allowed to screen on TV. But they will require more effort than that is possible at our level.
Just one suggestion, that at home we can insist that when a child receives his or her birthday gift, then we can give a, say, badminton racket or a skipping rope or something like that. That will be his own or her own, and he or she will think that I should utilize that. So that is one way to encourage the children at home. And for schools, I think if the class teachers scrutinize what tiffin they are bringing, and if they reward them for bringing, say, good healthy foods, then they may be encouraged. These are the ways to tackle it.
One comment about this cooking in the school. Like, same thing can be done at home, but what will you do about these Zomatos and the ordering food? Because children are learning right from a very young age, ordering food from outside. That has become a new normal in last 1 decade I've been seeing. So even if they are taught, or we all know cooking, but the easy way out is ordering the food. Like it is replacing the kitchen in the house. So that is a big concern.
No, the kids are not earning, no. We are paying for it. So we have to set our round straight. There was this one question from there. The last question for the day.
So for the Khushbu, so below 18 year in India, only for obesity, other than all this state, what can we use?
Liraglutide and semaglutide are approved, but not by DGCI. That will take time. But see, if you're not dealing with a genetic obesity, I think part 1, 2, 3 are more important. That's what I wanted to emphasize on. We all know the drugs. Yes.
Had it been so easy, Anant Ambani would not have been 150 kg.
Yeah. In extreme cases, yes, of course, you can try a drug, but you should keep the patient under follow-up. But I am not sure about these drugs before puberty. I would definitely not recommend them before they have completed their puberty. Maybe after puberty, if you have adequately given time and you are sure that there is no other barrier, probably you can give these medications a try.
Yeah, just a small comment on that use of liraglutide and semaglutide. Yes, wonderful drugs. They causes weight loss, but we need to remember that at the same time they also causes 20 to 30% loss of muscle mass, and our kids are building their muscle mass. So at a critical time when they are building their muscle mass, if they lose muscle mass or less development would be detrimental for future life. Although there are studies, drugs have been approved, but these studies have not addressed the question of loss of muscle mass. In adults, they have reached to peak of their muscle mass, but kids are still gaining muscle mass. So yes, there is 20-30% loss of muscle mass also, and same with the bariatric surgery. Not applicable for monogenic causes of obesity like she presented. For monogenic, we have altogether different. But for routine garden variety obesity, these things should be kept in mind that muscle mass would be interfered, and they may not reach to their maximum muscle mass. So we are building a child with less peak bone muscle mass will put that child in lifelong risk of sarcopenia throughout her life.
Sir, but for a child who is suppose 150 kg at 17 years of age, and he's unable to do exercise because of the weight itself, and so if we just start for 3 months.
Absolutely agree. Monogenic causes and these causes, yes, we use. But for routine obesity, we are seeing nowadays some parents are approaching, you give Monjaro for my daughter for 2 years, so she will reduce weight, and weight is not very high. Just with the height of 157 or 158 centimeter, weight is 70 kg or 75 kg. But seeing this pharma approach, many people are approaching that, why don't you give for a year? So that thing we need to take control of that for monogenic obesity, and somebody who is 156 kg, even what Monjaro will do or what semaglutide would do would be questionable. They may have 15-20% weight loss, but it still remains massively obese.
Thank you so much. This was an engaging session. I called it the end of the session. Thank you so much.
So I thank the chairpersons for excellently moderating this session, as well as the excellent speakers. So as the time flows, we have to move towards next session, despite our we had wished to have discussed more. So for our next session, I would like to call upon stage none other than Dr. Krishna Vishwas Madam, who is the director and the founder member of endocrinology at the Safdarjung Hospital in New Delhi. And along with it, I will now call upon Dr. Indira Maishnam Madam from our very own Institute of Postgraduate Medical Education and Research, Kolkata, for chairing this session on growth and its nuances.
Thank you so much for the kind introduction, and thanks to the organizer for organizing a visit to my city of joy. First, without delay, I call the first speaker, Dr. Bhagesh IRS, who is professor and former head of Department of Endocrinology, St. John's Medical College and Hospital, Bangalore. His topic is an interesting topic, which pediatric endocrinologists do face. Evaluation of the GH-IGF-1 axis, potential pitfalls. So over to Dr. Bhagesh.
Good morning. At the outset, thank you for organizers and also chairpersons for the introduction. I think I'll take you for next 15-20 minutes evaluation of GH-IGF axis, potential pitfalls, mainly a negative talk. We'll be telling really bad about the axis, but it's not true in the whole sense. Yeah. So just case, I'm going through a case thing, and two identical patients, 10-year-old boy. This is probably a time where most parents bring the child with a short stature, height of 118 centimeters, weight 27 kgs, all far below the expected levels. Growth velocity is less. Bone age is also 2 years less. So as usual, screening test has been done after the routine tests which were normal, and 2.5 standard deviation less of IGF-1. GH stimulation, most of the time, I think most convenient thing to do is a clonidine, though the ITT being the gold standard. The peak is 9.4. I think 7 is taken as a cutoff. Some even take 10 as a cutoff, but by and large reported as a normal. So nothing needs to be done, only reassurance for the patient, but parents are concerned he's still short. The second patient, again, 11-year-old, 125 centimeters, weight of 24 kgs. Growth velocity is good, but many a time it can be misleading. IGF is low, but GH stimulation is less than 5. Reported as a GHT, they want a treatment to growth. So in these cases, most of the time we get a confusion what to do, but some of the cases is quite simple. This is a child of a syndromic child, RSS, no test is required, give a treatment, they grow like anything. So you can see the growth from the age of 5 years to the 10-year-old, even the child moved to the other city, and the pediatrician refused to give because all the RSS features were disappeared on treatment. And for even a Turner's, we don't have any difficulty. But difficulty comes, yes, this is a proven case of a GHT, but your test result doesn't fall in the expected line. Like this twins, the brother and a sister, and also this fellow visited us at the age of 27 years with just 77 centimeters, where the report comes normal. Okay, they will be confused why report is normal, child is short. Like, this is the places where we need to understand the GH and IGF axis. Just to brush up the flow chart, I think most important is an oxology following the history and also pubertal staging. Then comes the good physical examination to rule out some syndromic thing. Use appropriate charts and also proportionately, otherwise if you are using some charts for some other countries, it can be entirely different. Do a screening laboratory test, routine doesn't take much time, most of the time it tells the appropriate etiology for the short stature. If all the tests are negative, then go ahead with the endocrine testing. So endocrine testing doesn't come first, it comes last. So nowadays, I think IGF-1 being available everywhere, but still in certain centers, growth hormone being done first. Based on your expertise and availability, you should plan your flow chart. There is no one single dictum which should be followed everywhere, but just suit to the requirement of your department and the hospital. If IGF levels were low, then we need to do a GH provocation test. Need not be required in all, but most of the time, a common garden cases, you may have to do a 2 provocation tests. Sometimes even 1 is enough. If peak is less, brand it as a GHD with even imaging and all. If GH peak is very much high, probably we have to go with IGF generation test. I think in the past 1 decade, we have done only 1 or 2 cases. Yeah. So that's why most important is the clinical context. Oxology and the endocrine evaluation is the most important. Then comes the GH and IGF testing. And it is fought with lots of pitfalls, both from the time of a physiology, assays, and also patient factors. Just to recap the algorithm, how the growth hormone acts, I think GHRH stimulates, GH comes out, it acts on the liver, it releases the IGF-1, it is in the circulation bound to the ALS and IGF-BP3, and that's how it brings the effect on the final tissues. Though GH do have a direct effect, whereas IGF-1, 70% of the IGF-1 comes from the liver, rest comes from the local production. It gets regulated from GHRH, ghrelin, and the sexTRs, which stimulate the growth hormone secretion, whereas somatostatin suppresses, IGF-1 suppresses, so also glucocorticoids. So whenever growth hormone, I think highest during neonatal, during the intrauterine phase, on delivery it comes down, and again it goes up during childhood and puberty. Nearly 3 times it goes up during childhood and puberty. After 20 years, every decade it comes down by 14%. Above 60 years, almost it is like a GHT thing. Above 60 years, your growth hormone is very less. That's why adult growth hormone has been met with lots of hurdles, and we are not having very clear consensus when it comes to the treating adult growth hormone deficiencies. The question comes, why it is difficult to evaluate growth hormone and IGF-1 axis? The reason being, just a random sampling of a GH is not possible. It has got a circadian, and also it varies. So random sample is not helpful. When it comes to the IGF-1 level, it has got an age. I think beyond the age of 5 to 7 years, it's much more useful. And sex and puberty dependent. And in the puberty, it has got a highest level. More than low values, I think high values of IGF-1 IGF levels have been remained very constant. I think only there are 3 clinical situations you get high IGF-1 levels. The first one being the puberty, then the pregnancy, then the acromegaly. I think high IGF-1 levels have been very, very consistent, whereas for a low, we have got many causes. So there is no single test which can definitely diagnose GHT. It's a clinical in combination with a test. There is no gold standard, though we say that ITT being the gold standard, not being routinely performed in all centers. Probably few academic centers are still following. I think in the West, to a great extent, barring few countries in Europe, it has been given up. And that's the reason most of the time the evaluation starts with a static test of IGF-1. So IGF-1 is a quite stable. It is an integrated secretion of GH, minimal diurnal variation, no effect of the BMI. So GH has an effect of a BMI. Obese people have got a lesser GH levels because of a rapid clearance, but that doesn't happen with the IGF-1. That's why it's been used as a first screening tool for suspected GHT if patient is affordable. But when it comes to the distribution of IGF-1, it is quite varied. You can see in a normal subject, right between below 5, you can see even above 95. Across there is a IGF-1 levels. Even a normal children who have got a short stature, yes, you can see many levels above 50 centiles. Even a patients with proven growth hormone deficient, there are levels which overlap in the normalcy. That is the reason the difficulty comes in a GHT proven, if it is in the normal range, what to do. So the specificity is the one which is a problem when it comes to the IGF-1. So in a younger, less than 7 years, has a poor sensitivity. Even 40 to 50% of the young short children who have proven GHD, IGF levels can be in the lower reference range or around the just above the 5th centile. This low specificity is the one which makes difficult to rely on a single measure, and even the specificity starts coming down as child increases. Overall, it's about 2/3, around 70% above 10 years. So overall specificity, if you look into the childhood and adolescent together, it's around 70%. We say that any test which has got below 75 by and large is not good, but this is the one which has got around 70%, still we rely on it. So it is quite dependent on the nutrition. Few days of a malnourishment, low IGF-1 levels will be seen, but GH levels can be on the higher side. This is the one way to get a high GH level. Starve the kid for 48 hours, do a GH will be on the higher side. Fine. But IGF will be on the lower side. It can vary as much as 40% from one day to the other day. Lot of technical challenges when it comes to the quantification. I think nearly 25 years back, we did our first IGF-1 assay when I was doing my residency. Including acromegaly cases, it came as a low one. Then we found that probably we had not maintained the temperature of those serums adequately. This was our first experience with IGF-1 nearly 25 years back. So It can be a normal in a mild GHT, even a partial defects, wherein the levels can be seen in the lower reference range. And we need age, sex, and the Tanner stage specific ranges. That will be much more work required to do it. So IGF-1 levels is reduced in many cases. It is in a GH deficiency, that's what we are looking at. There can be a neutralizing antibodies of a GH reduces the IGF-1, malnourishment, malabsorption, patients with renal failure, hepatic failure, severe illness, even very rarely mesotheliomas, that IGF-2 producing tumors can have a diminished levels, and some amount of a decrement can come with patients who have got a obesity, and also in the malignancies, diabetes uncontrolled. When we say uncontrolled, they have seen that above HbA1c of 8, by and large, we call it as uncontrolled, which has got impact on the testing. Patients with CDGP and also patients with hypogonadism, you can have a moderately reduced IGF-1 levels. That's why whenever you interpret IGF-1 levels, you look into the patients and patients' physical examination, exclude many things, then rely on the testing. Then comes the GH stimulation test. Stimulation is the one most important when it comes to the deficiency disorders in endocrinology. Random is not important. We need to test the reserve. Earlier, traditionally, they wanted 2 tests to be positive to give the therapy because the growth hormone was limited in supply. Now we have got a surplus in supply and we are finding more indication. That's why you can see even the cutoffs being changed. But all these GH stimulations are non-physiological. So poor reproducibility is there in the same child in 2 different centers across 2 different time period. It can be a different. Best example is before puberty and after puberty. You can see so much difference in the GH stimulation testing. Stress, sleep, even a fasting affects the responses. And also there is no universal cutoff. Over past 5 decades, you can see the change in the cutoff. Before 1970, it was less than 3, then it became less than 7, it became less than 10, and now it is less than 7. So even the cutoffs have been varied, and it has to be center specific and also a test specific. So multiple GH sampling needs to be done to prove a growth hormone deficiency. By and large, they have found that 98% of the time, 2 hours time is good enough to find out most of the cases. So 2 hours testing, you will find out whether they are deficient or in 90%. 2% is very, very less when it comes to the spectrum of the disease. So provocative tests have got lots of problem. It's based on the reserve. Will give a pharmacological, very rarely a physiological things to produce. Most of the time it is pharmacological stimulation test comes. There is difference between the assays, and one study done in the UK, I think they assayed in the same test in a different, in same children in a different labs, there were different reports. It needs to be assay specific. Cutoffs, what we are following is regardless of the agent we are using, every test has got a different cutoffs. Clonidine and the GHRH has got a higher level cutoffs when it comes to the only a clonidine or an ITTN. So even the peak levels have been changed. I think anything less than 7 is a good, but still we may miss some partial GHTs. Most important physiological test is exercise. 30 minutes of exercise does increase growth hormone, but it is not practicable, not quantifiable, how much meds child has to do, and by and large, it's being used only in the earlier time, not being used routinely. Sleep does produce increased growth hormone, especially in the stage 3 and stage 4 of NERM, but for that, we need to have an indwelling catheter. Continuously, you have to draw over a period of sleep time. This is also labor intensive, may not be practical in all setups. Most important, what we traditionally learned as a residents, I think now only we do in very rare cases. So ITT has been traditionally a gold standard. When we see gold standard means we rarely use it. Fine, it's only for a learning or just for the exams. And it has got its own problem. I think in many countries it's not been used. In few countries in UK it's been used. Adults, we can't use because of lots of contraindication. Clonidine by far commonly used test, quite simple test. It does stimulate hypothalamus to release GHRH, and also it it inhibits the somatostatin secretion. 3 samples by and large is adequate, quite safe. Only thing we need to keep the child till evening. When the drowsiness goes off, blood pressure is stable, then we can send the patient. Arginine stimulation test is again reduces the somatostatin stone from the hypothalamus and has got an unopposed action on the GHRH. Not much experience in using this. Most of the time we are using combination of a test and concluding on a clonidine test to assess the growth hormone. In obese children, this can be on the false low values, quite poor specificity. You can't use this single test as a diagnostic test. Glucagon, yes, being available, is been used in many centers, and we do have few experiences. But initially, when glucagon testing came, initial results were quite not good. That's why they combined talbutamide and the glucagon. They started doing it, and now we know that we need to do for a longer period. It can be 120, 160, or even a 180 minutes to get the result. By and large, an injection of IM, subsequently, child can have a nausea, vomiting, but most of the time it will be admitted. Peak occurs late. Child has to stay in the hospital for a longer period, and it takes more longer time. It's mainly worked in the academic centers where you have got residents who can take care of the inpatients. Yeah. And it is contraindicated in the patients who have got a severe malnutrition. Levodopa is more of an academic interest. So oral levodopa will be given, quite simple, inexpensive. Nobody is following this. This is just for the sake of knowing that this test does exist. GHRH is quite encouraging. IV GHRH, many centers in the West are doing, and GH is measured over 15 to 60 minutes. Distinguishes hypothalamus versus pituitary defects. More very useful in the thing, but only experience with a few centers, limited availability, and quite expensive. So summarizing, I think there are many tests to do a GH provocation. Most commonly what we are doing is a clonidine followed by a glucagon. I think ITT has been restricted mainly to the academic centers and the centers which have got expertise to handle the hypoglycemia in a kid. Coming back to our patient A, this patient pitfall was a assay cutoff. In a different lab it showed think wrongly was reassured, and learning point, I think combine oxology, clinical contest, and many a time this will override whatever you get in normal GH. I think with treatment the patient became all right. The other patient which had a low IGF and low GH, which was referred for a GH treatment from outside, had a low hemoglobin. That's why I think doing a basic evaluation is a more important. ESR was on the higher side, and child had a Crohn's disease. And for this child, I think it was growth hormone was not indicated. I think treating the primary disease was more important. That's why I want to decode this. Anybody can decode this? Gagri. Clinical judgment is a gold standard. That I always keep that. I think especially when it comes to the endocrinology, pediatric endocrinology, it is always clinical judgment is a gold standard. Yes, tests are very important. Take use of the test to support your diagnosis. So this is a picture of the child who was seen nearly 1 week. I think he went back to Mangalore. I think Ganesh saw him for a few years, and this was our RSS child, grown very well and doing very well. To conclude, oxology is the first thing we have to do, and bone age remains the cornerstone. Biochemical tests only support your clinical decision. IGF-1, quite useful, but it has confounded by the age, puberty, nutrition, and illness. GS stimulation, there is no perfect test. Poor reproducibility, and integrated approach is the most important. History, clinical examination, oxology, routine biochemistry, then the specific test. acknowledgement for our resident Siddharth for a preparation. Thank you for all of you for the patient hearing.
We'll discuss, have the discussion in the end of this session. Now we have the next talk, and the next speaker is Dr. Kumaravel V. Can we have his slides? Yes, okay. So, sir is currently affiliated to Alpha Hospital and Research Center, Madurai, and he has a lot of publications, as we can see. And he will be speaking on growth monitoring and management in a child with juvenile idiopathic arthritis. Sir, please.
Respected chairperson, co-speakers, and my dear friends, and special thanks to Team Bengal for this opportunity. And I am going to talk on growth monitoring and management in a child with juvenile idiopathic arthritis. So this is the overview of my talk. I would discuss briefly about what exactly is this juvenile idiopathic arthritis, the growth disturbances in JAA, and monitoring growth in children with juvenile idiopathic arthritis, what are the therapeutic strategies to preserve growth, and a concluding remark. So what is this juvenile idiopathic arthritis? So it's a chronic autoimmune arthritis starting before age of 16 years and which lasts more than 6 weeks. And it approximately affects 1 in 1,000 children globally, and it is more common in females. And there are 7 clinical subtypes. It's very important for us to know these things because your severity of growth disturbance depends on what is the subtype of disease the patient is suffering from. So you have systemic juvenile idiopathic arthritis. You have oligoarticular JAA, where less than 4 joints are affected. You have polyarticular, where more than 5 joints is affected, and it could be rheumatoid factor positive and again negative. You have psoriatic juvenile idiopathic arthritis, where you have arthritis with psoriasis. You have enthesitis-related arthritis. You have undifferentiated arthritis. So each subtype carries different implication for growth potential, with systemic and polyarticular forms typically associated with more significant growth challenges. So the clinical picture of JAA, as you all know, definitely they'll have some form of joint manifestation, and you can have systemic features also, which includes high spiking fevers, rash, hepatosplenomegaly, serositis in the form of pericarditis or pleuritis, and they can also have lymphadenopathy. The disease course is very important, especially in patients with JAA is concerned. You can have a patient with a monocyclic disease where you have a single episode with complete recovery. You can have a patient with polycyclic where you can have a periods of remission and flare-up, and you can have persistent disease where you have continued disease activity without remission. So your disease course significantly affects your growth trajectory with persistent disease and frequent flares presenting with highest risk for growth impairment. So your polycyclic and persistent forms definitely have higher growth compromise compared to a monocyclic form of juvenile idiopathic arthritis. And the predictors of poor outcome in JAA include whether if you have polyarthritis form, and whether if there is a delay in diagnosis, delay in onset of treatment, and rheumatoid factor positive, and when you have ankle, wrist, or cervical involvement, definitely your growth potential is retarded. Especially when your ankle and wrist is affected, naturally your linear growth tends to get affected also. So you can have more and more of growth compromise in these individuals. And I would say juvenile idiopathic arthritis causes more than visible joint symptoms, and the children's experience fatigue, chronic pain, and reduced physical activity, which can significantly impact their quality of life, education, and social development. So the combination of physical limitation and medication side effects creates a complex challenge for normal growth and development in a crucial formative years, and that is one reason why we are really concerned about your growth potential in those patients with juvenile idiopathic arthritis, apart from the rheumatological problems what the patient is suffering from. So the growth disturbance represents one of the most significant but often overlooked complication of juvenile idiopathic arthritis, because many times they are managed by rheumatologists or pediatricians. Very rarely they come for the endocrine perspective, or very rarely even the stature is measured for these patients, because they come with acute pain, and many times even the stature is not measured for these patients. And growth failure in JAA results from a complex interplay between a systemic inflammation, your medication side effects, your nutritional deficiencies, and disease-related factors which can disrupt your normal growth and development process. The prevalence of growth retardation is roughly around 10 to 40% in children with JAA who experience abnormal short stature or growth delays. There's 2 to 3 times increased risk in patients who have systemic or polyarticular subtypes compared with oligoarticular JAA. And again, when you have polycyclic and persistent juvenile idiopathic arthritis, definitely your growth impairment is more. And more importantly, children with growth impairment, they report at least 80% have a psychosocial impact and decrease in quality of life. So the growth failure has a profound implications beyond physical stature, and which basically affects self-esteem. This holds good for any patient with short stature, where you have a decreased self-esteem, peer relationships are affected, and you can have a difficult occupational exposure in future. So what is the mechanism behind growth impairment? Is it only the disease process? So as you all know, the chronic inflammation, especially pro-inflammatory cytokines, disrupt the growth hormone IGF-1 axis, and it can affect the growth plate. Local growth effects like joint inflammation, which accelerates local bone maturation, and it again can cause limb length discrepancies and asymmetry in patients with GAA. Corticosteroid therapy, which is the cornerstone which has been most commonly used, and of course we have newer therapies which are available. It suppresses the growth hormone secretion, it reduces IGF-1 bioavailability, and it also directly inhibits the growth plate chondrocytes. The nutritional deficits associated with JAA include increased metabolic demands to cope up with the chronic disease. There's a reduced appetite and malabsorption which leads to a calorie and protein deficiency, which could be part and parcel of a disease, or part and parcel of associated autoimmune problem, or your part and parcel of your medication what we have been using for these things. So all these mechanisms put together create a perfect storm for growth failure, with each factor potentially exacerbating the others in the negative feedback cycle. And we all know this nuclear factor kappa B is an important factor in regulating the inflammatory process in terms of cell cycle regulation, apoptosis, IGF-1 axis, inflammation and angiogenesis, and they can definitely, where more the infection or inflammation, it can definitely affect your growth factor. Apart from your chronic inflammation and apart from your nutrition, delayed puberty has been commonly seen in those patients with juvenile idiopathic arthritis, and JAA can have an effect on your bone health also. The median age of pubertal onset is delayed by at least 1 to 2 years in patients with JAA, and there's a reduced pubertal growth spurt amplitude and duration depending on the severity of the disease. And again, the pubertal delay is also associated with psychological distress. And more important, your bone health concerns, which we are in those patients, there's at least 30 to 50% reduction in peak bone mass acquisition. There's increased fracture risk. There's at least 3-fold higher fracture risk than the healthy peers in patients with JAA. You can even have a vertebral compression fracture in severe cases, which can affect your bone health and which can also compromise your vertebral height and your final stature. The long-term osteoporosis risk is persisting into adulthood in those patients with JAA. So your recommendation is that monitor your pubertal development every 6 months from age 9. You can use a Tanner staging, you can use your clinical skills in managing, and of course your biochemical testing should be done when and whether indicated, and your DEXA scanning for bone mineral density should be considered in high-risk patients, may not be required in all the regular patients. So how do you monitor the growth in JAA? What exactly you have to track? So early identification of growth deviation allows for a timely intervention before significant and potentially irreversible growth failure occurs. So early intervention and early diagnosis more important. So the essential growth monitoring parameters include your anthropometric measurement, which includes your standing height, your sitting height, your weight, and your BMI, and your basically you have to plot your height measurement and age appropriate growth chart. We can use whatever growth chart we want, and more importantly we have to track your height velocity over minimum of 6 months interval. What is more important in this anthropometric measurement is that many of these patients can have limb length disparities, so we are supposed to measure these disparities during a regular visit. So growth pattern analysis, you calculate your height for age Z-scores, assess whether they are crossing placentale, especially downward tracking of placentale. It should give us a red flag sign. Compare with target height based on their parental heights, and document limb length discrepancies if present. And of course, you may require a bone age assessment, annual wrist X-ray bone age determination, and compare your bone age with your chronological age, and calculate the predicted adult height using your bone age and assess the remaining growth potential. Of course, look at the pubertal development, and you assess for the pubertal development every 6 months from 9 years of age, and document the age of pubertal milestone achievement. I'm sure in every case sheet we have to document your pubertal Tanner staging and monitor for delayed puberty and track the tempo of progression through stages. And next to these things, you have to look for clinical and laboratory surveillance, disease activity monitoring, and look for active joint count, morning stiffness duration, and you can look for disability index. Of course, these things are done by rheumatologists. And your ESR, CRP gives you a clue how active your disease is. Look for a complete blood count and look for IGF-1, IGF-BP3, and look for your thyroid function test annually. Your higher your ESR, higher your CRP, or higher your inflammatory markers, they correlate strongly with growth velocity decline. So whenever your ESR is more than 25 and it is sustainedly ESR is elevated for more than 6 months, they can have a decreased amplitude in your growth velocity and it can cause a short stature. So imaging of growth and joint pain, as I said, bone X-rays are very important, and joint imaging can be done if you are looking at your growth plate destruction, and look for limb length assessment also. We have various advanced imaging techniques which allow for early detection of growth abnormalities before they become clinically apparent. And this can make you to treat them proactively with earlier intervention strategies. The goals of JAA management, you can have a basically you should address the physical, emotional, and social aspects living with JAA. We should control the inflammation, we should control the preserving the joint function, we should prevent the joint damage, maintain mobility, and more importantly, optimal growth and development. I think that is what is a concern as an endocrinologist we are there, because all other things could be taken care by the rheumatologist. And the therapeutic strategies to preserve and promote growth. So as I said before, management approaches must address the multifactorial nature of the growth impairment in JAA, combining inflammation control, medication optimization, nutritional support, and targeted growth promoting therapies. The treatment strategy requires a regular adjustment based on growth response with the goals for normalizing your growth velocity and maximizing your growth potential. So the various drugs which has been used for juvenile idiopathic arthritis, which could have a varied effect on your growth potential also. So early intervention is the key. Initiate treatment within 3 months of your symptoms onset to minimize growth plate damage. Always treat to target, aim for minimal disease activity, or aim for a clinical remission using validated composite measures or standard of care. Step-up approach, escalate therapy aggressively if inadequate response is seen within 6 months. So the common medication class which has been used, you have NSAIDs, methotrexate, TNF inhibitor, and various interleukin blockers. NSAIDs have a minimal direct effect and they are beneficial in reducing the inflammation. They have a minimal effect on your growth potential. Methotrexate has a neutral or positive effect by controlling the inflammation. TNF inhibitors, they have an improved growth velocity by at least 3 to 5 centimeter per year in responding patient, and this is basically by controlling inflammation and by controlling a disease process. Your interleukin blockers significantly also have a growth improvement, especially in systemic JAA. So the evidence for all these things are strong, and these disease modifying agents can have a better effect in your growth potential apart from controlling your disease process. So if at all you are using corticosteroid, always use the steroid sparing strategies. Use alternate day dosing when possible, which can have a less growth suppression. Consider intra-articular steroid injections to limit systemic exposure. And always aim for a steroid-free regimen within 3 to 6 months of initiation. We should be able to control the disease and try to taper the steroids as early as possible. And always implement a steroid tapering protocols with defined milestones. Introduce early biologic therapies to facilitate your steroid reduction. And this intra-articular steroid injections can also provide a targeted therapy for minimal systemic effects on growth, especially valuable for a single joint or oligoarticular juvenile idiopathic arthritis. Biologics, game changer for growth in JAA, and you have a targeted cytokine blockade. We have etanercept and tocilizumab, which are linked to improved vertical growth rates. So block specific cytokines which disrupt a growth plate function, and early initiation correlates with a better growth outcome. And studies have shown up to at least 70% of growth which are impaired in JAA patients demonstrate a catch-up growth within 2 years of biological initiation. So even without growth hormone controlling this disease, and with this biological, you can be able to have a catch-up growth. Growth hormone therapy, when and how? I think indications used in children with persistent growth failure despite disease control. This is off-label use only, of course, and it is most effective when inflammation is low and steroid dose is minimized. It should be considered only when your height velocity is less than 4 centimeter per year despite optimal JAA control, and height Z-score less than 2, and which is also declining, and whenever predicted adult height significantly below target height. Otherwise, your growth hormone therapy may not be indicated in these patients. Controlling the inflammation biologicals itself will help you to have a catch-up growth. Efficacy, it can induce a catch-up growth comparable to growth hormone deficient children. It improves your final adult height when started appropriate time, earlier the better. So consideration requires a daily subcutaneous injection growth hormone. We have another talk on growth hormone also, and it needs a careful monitoring for side effects and efficacy, and cost and availability concerns are a different concern in some region. So the growth hormone therapy in JAA, typical doses 0.05 milligram per kilogram per day subcutaneously, daily evening administration. It is not FDA approved indication, and treatment duration minimum 2 to 3 years or until your final height is reached, and regular monitoring of IGF-1 levels to adjust the dose, and more importantly, your disease process has to be under control. The expected outcomes: first year your height velocity could increase to 3 to 5 centimeter per year. Your adult height gain is roughly around 4 to 10 centimeter depending on various studies, and best results are seen when started with a low disease activity compared to a high disease activity, and response is attenuated with ongoing steroid therapy. So we should have a low disease activity, and we should be out of steroids, and then only you will have a better response with these drugs. So it requires a multidisciplinary care. You require support from a rheumatologist. We require a support from a psychologist, and the role of endocrinologist is just to monitor growth and puberty assessment and growth hormone therapy only when required. So we require a physiotherapist support to look at the joint mobility and muscle strength exercises, which itself can improve your growth, and dietitian nutritional support addressing your deficiencies and bone health. Just to conclude, the integrating growth monitoring into JAA care is very important. The key insights include growth impairment is a significant multifactorial complications affecting at least 10 to 40% of the children with JAA. Early diagnosis, tight inflammation control, and minimizing steroids are a fundamental prevention strategies. Growth hormone therapy offers additional benefit. I will underline it just offers additional benefits when and timed appropriately after inflammation control. The best practice is to implement standardized growth monitoring protocols in all JAA patients from diagnosis. Talk to a rheumatologist or talk to a person who takes care of your JAA, and always try to implement a standardized growth monitoring protocol, and utilize multidisciplinary teams including pediatric rheumatologists, endocrinologists, or nutritionists, address both physical and psychosocial aspects of growth impairment, and consider sequential therapeutic approaches for optimal outcome. Development of predictive models for early identification of high-risk patients would be a future goal what we want to achieve, and optimization of growth hormone therapy protocols which should be specific for JAA subtypes, which we don't have now, and investigations of novel anti-cytokine therapies with growth promoting factors are also on pipeline. Long-term outcome studies into adulthood has to be done. So by implementing a comprehensive growth monitoring and management strategies, we can definitely significantly improve both physical outcome and quality of life of our children. And thank you so much for this opportunity, and I will stop with this.
Thank you so much, Dr. Kumar, for this nice elaboration of the condition, which is not so much discussed. Next, I invite Dr. H.K. Ganesh. He is Professor and Head, Department of Endocrinology, AIMS, a consultant endocrinologist, AG Hospital and Research Center, Mangalore Endo-Diabetic Clinic. He has numerous publications. He will be talking on long-acting growth hormone preparations, current status, and future considerations. So over to Dr. Ganesh, please.
Thank you, madam. At the outset, I would like to thank the organizers of this wonderful SECon 2025 for giving me the opportunity. For the next 20 minutes, I will be speaking regarding long-acting growth hormone preparations, what is the current status, and what are the future considerations. I will be first discussing what is the need for long-acting growth hormone therapy. Then I will discuss regarding the available growth hormone preparations, their mechanisms, efficacy and safety data, and finally future considerations. Few slides on future. Just now we heard from Dr. Vagish regarding the growth hormone physiology. It's secreted in pulses. The main majority of the pulses occur at night during sleep. Any replacement in endocrinology has to be more and more physiological. It should not be pharmacological, it should be physiological. So whenever we are replacing some hormone, we should try to mimic the physiology. But the treatment started with pituitary growth hormone long back in 1970s. But the development of Creutzfeldt-Jakob disease, because of that was withdrawn. And by 1990s, the recombinant DNA technology came up. The insulin came with the recombinant DNA technology, and the growth hormone was also manufactured by recombinant DNA technology. So, but what we are giving as daily growth hormone doesn't mimic the physiology. It has got half-life of 3 to 4 hours. It has got unimodal blood pattern, but it has shown good response. The growth response in children is very good with the recombinant growth hormone therapy. But the continuous infusion studies of growth hormone, which tried to mimic the physiology, didn't demonstrate any clinically meaningful response. Even though it was mimicking the physiology, it doesn't give extra response. So probably what we are giving is good enough. But what is the problem? Adherence, especially in Western countries where the insurance is giving. Here we are giving out of our pocket. So that is the reason probably adherence is better. But when it is given by insurance, the adherence is a big problem. So this was a study done in New Zealand actually by Cutfield et al. It has shown that the adherence is poor. So when the adherence is poor, only 30% of the patients have had good adherence, that is missing less than 1 dose per week. And 66% of the children who missed more than 1 dose of growth hormone per week had a significantly reduced height velocity SDS. So adherence remains the key, and there was a famous quote by Everett Koch, drugs don't work in patients who don't take them. So that's absolutely true. Adherence is the key. Not only in the field of growth, in other fields also, the adherence is a problem. That is the reason in hemophilia, long-acting factor VIII has been tried and it's giving good response. In diabetes, all of us know, the weekly exenatide, semaglutide or dulaglutide or tirzepatide, they give better response compared to daily GLP-1 therapy. So that is the reason, probably this is one of the reasons why LAGH, long-acting growth hormone, is required to avoid daily injections, to maximize the efficacy and to improve compliance and to improve flexibility. So for the ideal candidates for long-acting growth hormone therapy, children at risk of poor adherence, especially in the teenagers who are rebellious, and children taking other multiple medications, children with neurodiversity, the fear and anxiety, the children usually they are very much anxious to take injections, even the parents. So in them, probably long-acting growth hormone is a welcome treatment. Children with frequent travel schedules and who are staying in residential schools. In residential schools, it is very good because they can come in the weekend and take injection and go back. So that there will not be any peer pressure, or they will not have to expose the injections to other children. But there are some questions which need to be addressed, whether the long-acting growth hormone is as effective, as safe, or whether it really transforms into better adherence in real life, whether it gives better quality of life, and finally, in our setting, most important, whether it is cost effective. And some of the other practical questions, the methods of dose adjustment, how to adjust the dosage, And second, IGF-1 monitoring. I'll come to it in my later slides. The IGF-1 level is not actually exactly doesn't follow the pattern. There's a peak and trough with the long-acting growth hormone. So what are the long-acting growth hormone preparations available? What are the mechanisms by which we can prolong the action of growth hormone? So first is depot formulation, which was available in India previously, but it is not available now. Utropin plus, pegylated growth hormone, Gintrolong, then modified growth hormone with increased albumin binding. That is the same mechanism as our Detamir or Degludec, somapacitan. The prodrug formulation, that is Lonapeg somatropin, and growth hormone fusion proteins like somatrogon. These are the various long-acting growth hormone preparations. I'll discuss one by one. The first depot growth hormone preparation which was available was Neutropin depot, which was made available in 1999. It was in the form of biodegradable microspheres. From once it's injected, these microspheres get dissolved and slowly gets released. There will be sustained release of growth hormone. But there was a lot of issues like injection site reactions, nodules, erythema, post-injection pain, and though it produced good growth, good catch-up growth, good improvement, but there were issues. Because of this, it was withdrawn. Then came the Utropin Plus from South Korea actually, using microsphere technology. In this, the growth hormone is incorporated into sodium hyaluronate microspheres suspended in medium chain triglycerides. So once it is injected, this tissue hyaluronidase dissolves this and slowly it gets absorbed into the capillaries. Height velocity wise, it showed good response. Efficacy wise, it was very good. But the large volume of injections, higher initial burst release of GH, then protein aggregation rates, all these were the problems with this Utropin Plus. So it was actually now not available in India, but still available in Korea. Gintrolong, it's available in China. It's a pegylated growth hormone formulation. It's a irreversible pegylation. The polyethylene glycol is attached to the growth hormone molecule, making it the action prolonged. Pharmacokinetic studies demonstrated the potential for once weekly dosing, and the children showed good height velocity and higher serum IGF-1 levels compared to daily growth hormone therapy, but it's available only in China. Then the next, Transcon GH or Lonapeg somatropin. It's a reversible, uses the mechanism of reversible pegylation. Here there are three components. One is growth hormone, second inert methoxypeg carrier, and third is transcon linker. So once it is injected into the subcutaneous tissue at a physiological pH and temperature, you can see here, so this is a growth hormone, and there is a transcon linker and transcon carrier. Once it is injected into the subcutaneous tissue, it gets dissolved in the physiological pH and temperature. So the growth hormone gets released. That's how it works. So it works for more than a week. So the trials have clearly shown that it is very efficacious. It's available in US. So this was the trial, the first trial with Lonapeg somatropin, the high trial in which the growth hormone naive patients were given either the Lonapeg somatropin and compared with daily growth hormone therapy, and height SD was better with the Lonapeg somatropin. And another trial, FLY trial, in which the people who were on other formulations of growth hormone were shifted to Lonapeg somatropin, and that also showed improvement in height SDS. And the open label extension of these trials, Enlighten trial, also showed good response with Lonapeg somatropin. So children treated with weekly doses of Lonapeg somatropin showed continued improvement in height SDS, and it was found to be efficacious and safe. And it is approved by the FDA in children and adults for growth hormone therapy in US. Then came somapacitan, which uses the reversible albumin binding as the mechanism. So it's manufactured by Novo Nordisk using the same principle as Detamir or Degludec. It has got one single amino acid change at 101 position. There is a fatty acid attachment which helps in non-covalent albumin binding, and that gets released slowly in the blood. So that's why it can be used once weekly. The trials with the somapacitan, the real one trial, the first trial done with adults with growth hormone deficiency, and at the end of 34 weeks and 86 weeks, there was significant reduction in truncal fat percentage as well as percentage change in visceral fat, suggesting that it is efficacious in patients with adult growth hormone deficiency. So, somapacitan administered once weekly demonstrated superiority over placebo in patients with adult growth hormone deficiency, and it was useful in reducing abdominal fat and increasing in skeletal muscle mass. Then came the dose finding study in children, real 3 study. At the end of week 26 and week 52, the 3 different doses were tried, and it was found that 0.16 milligram per kg per week provided the closest efficacy match and with similar safety and tolerability to daily growth hormone. So, somapacitan 0.16 milligram per kg per week is as efficacious, and it's yet to be made available in India. Probably this year end or the next year it will be made available. So, the real 4 study, this is a phase 3 real study of somapacitan. Once again, comparison with the daily growth hormone, annualized height velocity and IGF-1 levels were comparable to daily growth hormone. So, at the end of 52 weeks, that is at the end of 1 year, the annualized height velocity was similar to daily growth hormone therapy, and IGF-1 SDS was comparable to daily growth hormone therapy. Next came the fusion proteins, another mechanism by which the growth hormone action can be prolonged. So, the biggest problem with this fusion proteins, the molecular weight increases, the molecular weight becomes more than 40 kilodalton, so that can hamper its ability to penetrate the growth plate as well as activating the lipolysis in adipose tissue. But studies have shown that it is efficacious. Somatrogon has shown good response in children with growth hormone deficiency. Somatrogon is actually here the fusion protein. Here 3 CTP carboxy terminal peptide sequences from the beta chain of SCG is incorporated into the growth hormone. 2 copies fused at the 3' end and 1 copy fused at the 5' end. The half-life of somatrogon is approximately 28 hours. So that's how it works longer. So the phase 3 study in which weekly somatrogon was compared with the daily growth hormone showed good response. Height velocity SDS as well as annualized height velocity was comparable to daily growth hormone therapy. So efficacy of once weekly somatrogon was non-inferior to once daily somatropin with similar safety and side effect profiles. So coming to monitoring of long-acting growth hormone therapy, so I will be mainly telling regarding the somatrogon, which is already available, and somapacitan, which is about to be make available. Serum IGF-1 concentrations we are supposed to monitor, ideally 4 days after the prior dose, because the IGF-1 levels will be at the peak in the 4th day. The goal is to maintain the IGF-1 concentration within the upper normal range without exceeding +2 standard deviation score. And IGF-1, if it is more than 2 SDS, then we are supposed to reduce the dose by approximately 15%. And if one dose is missed, within 3 days, we can give the missed dose. If it is more than 3 days, better to go for the next dose. So this is the pharmacodynamics of long-acting growth hormone. So after the injection, the peak IGF-1 levels are seen in the 3rd or 4th day, then comes down, and it's usually at the trough level before the next injection, scheduled injection time. So this is a rough table comparison of 3 growth hormones, lonopeg somatropin, somapacitan, and somatrogon, probably not very much visible, but I can summarize. The clinical evidence wise, the lonopeg somatropin was superior to the daily growth hormone, whereas somapacitan and somatrogon were non-inferior. The molecular weight wise, only somatrogon is having high molecular weight, more than 40, around 40 kilodaltons. Dosing wise, the higher dose is required for somatrogon, 0.66 milligram per kg per week. Lonopeg somatropin 0.24 milligram per kg per week, and somapacitan 0.16 milligram per kg per week. And the storage wise, it can be stored for about 6 months in lonopeg somatropin, whereas it's up to 72 hours in somapacitan and only few hours with somatrogon. Approved indications, it's adults as well as more than 1 year. It's approved with lonopeg somatropin. With the somapacitan, more than 1.5 years in children and adults, and somatrogon only children more than 3 years, approved indications. So lower starting doses are advisable in children with obesity or obese adults also. Increased risk of intracranial hypertension, severe growth hormone deficiency, genetic or chromosomal abnormalities, renal failure, or on estrogen supplementation, better to go or start slow. Once there are no side effects or no issues, we can increase the dose. So LAGH to be used with extra caution in survivors of cancer and intracranial tumors associated with GH deficiency because of the risk of high IGF-1 levels. So the high IGF-1 levels, whether they have any issues with the future malignancy. So that is the reason we have to use with caution. And Prader-Willi syndrome, we have to use with extra caution. We have to start slowly, probably half the dose we have to start with, and then slowly build up because of the risk of obstructive sleep apnea. Very young patients, probably better not to use the long-acting growth hormone therapy because of the trough levels which we see before the next injection schedule can precipitate hypoglycemia. So that is the reason probably in very young children, probably less than 3 or 4 years, better to go for daily growth hormone rather than weekly growth hormone therapy. And pediatric non-growth hormone deficiency states, Turner's or Noonan's or Prader-Willi, we don't have much data. Probably in them it's better to go for daily growth hormone rather than long-acting growth hormone therapy. There are some potential safety issues. The neutralizing anti-drug antibodies in somatrogon trial, up to 70 to 80% of the children developed anti-drug antibodies, but the efficacy-wise there was no issue. So the anti-drug, anti-growth hormone antibodies which were found in children who are taking somatrogon didn't have any effect on the growth or efficacy, but safety we don't know, the long-term safety. The growth and metabolic effects related to the profile of serum GH and IGF-1 levels during therapy, the peak growth hormone and IGF-1 levels, because IGF-1 we saw the pharmacodynamics, the IGF-1 levels are much higher compared to daily growth hormone therapy. Whether it has got any untoward effect in the long run, whether it has got any cancer risk in the future, that we are not sure. And sustained long-term elevation of IGF-1, whether it can induce subtle acromegaly features, we are not sure. And trough levels at the end of the dosing period, whether it has got any effect on growth and metabolism, that is also not very much clear. So these are some of the potential safety issues we have to think before starting long-acting growth hormone. Some of the other concerns, non-physiological growth hormone profile. So, but even daily growth hormone is non-physiological. We can't say that the only long-acting growth hormone is non-physiological. Lack of optimal therapeutic monitoring guidelines, we are supposed to do at the 4th day, but we don't know. In some children it may peak at the 3rd day, some at the 5th day, we are not sure. Potential novel side effects related to the technologies used, because various technologies have been used to prolong the growth hormone action, whether this per se, the polyethylene glycol which we are injecting, whether it has got any side effects which we don't know. Cost effectiveness, the cost is much higher, usually double the cost of daily growth hormone therapy. So whether we are justified just because the adherence or compliance for that sake, whether we are justified in doubling the cost of therapy, which is already costly. Unique pharmacodynamic and pharmacokinetic profiles of different preparations. This also we have to think of, because each is different. Suppose the child is on somatrogon, suddenly it became unavailable. So you are shifting to somapacitan. So whether the efficacy is similar, we don't know. That also the thing we have to think of. Molecular size and tissue penetration. The somatrogon is having higher molecular weight. So though the studies have shown the efficacy, in research models, the ability to penetrate the growth plate was lesser. We don't know how the efficacy has been happened then. Probably some other charge or some other issue may be there. Lack of long-term safety data, this is one of the major concerns. Coming to the future needs, establishment of observational outcome and safety studies or registries for long-term follow-up treatment of growth hormone, long-acting growth hormone. Comparison of treatment of LAGH with the different underlying diseases, not only growth hormone, other conditions. In adult growth hormone deficiency, we should have data. Evaluate development of anti-growth hormone antibodies in patients switching between different LAGHs, and compare the cost effectiveness of daily growth hormone injections and LAGH in adults and children with growth hormone deficiency. Concluding my talk, long-acting growth hormone definitely improves compliance and adherence. Lonapexamatropin and somapacitan, they are approved in children as well as in adults. Somatrogon is the only available LAGH in India, and it's approved only in children, not in adults. Long-term safety issues and effects of very high IGF-1, not yet very clear. Thank you.
Thank you, Dr. Ganesh, for this elaborate talk on long-term, long-acting growth hormone preparation. All three speakers, please come to the dais and now it is open for discussion. Yes, Dr. Khargawat, please.
Yeah, wonderful presentation. Just add to Ganesh's lecture, we have received communication from Israel for starting once a month preparation. So that is latest development is still in phase 1. They are completing phase 1 and they want to enter phase 2. So that is the latest development. Maybe 2-3 years Ashikon down the line we would be discussing once a month also. And second thing, we have received protocol for oral GH.
Great.
So oral GH daily in form of tablet. By next month we would be starting that trial. So these are two development, and our center have been involved in all 3 molecules. We have done registration trial for LG long acting, we have done for Pfizer, we have done for Novo. Somapacitan, Somatragon, and other one is which is disappeared from the market. Utropin, it's worked well, but only thing is they could not supply outside Korea. Their manufacturing capacity was limited, so that's why they discontinued in all countries except South Korea. South Korea, it's still in being used. And in India, this Chinese growth hormone, it's got almost approved. So maybe in next 6 months we will have that's also available in our market. Having said that, you said that you will discuss about cost also. We analyze our data. Nobody discontinued growth hormone. For injection, nobody discontinued. So discontinued comes from the Western countries where government is paying for your injections. If your family is paying, nobody discontinues. And on a cost, 10 to 15% or 20%, we are paying higher if we are using once a week growth hormone. So cost is definitely high in comparison to the daily growth hormone. And our main problem is cost. Our not quality, everybody will understand that, and most of our children are diagnosed late. They are very short, they are bullied in their class, so nobody misses even a single day. Only chance of missing is they do not have money. So if they do not have money, they will not be able to buy once a week also. So whatever New Zealand people are saying, yes, that may be good that if you are missing, definitely drug will not work. But if they are not missing, then daily versus weekly are absolutely same. Both Pfizer and Novo long-acting growth hormone, they worked on non-inferiority. Nobody was superior. So they are non-inferior to the daily growth hormone, which works well, and 10 to 15% cost is less. So still, it's not going away from the market. Still, this is available.
Yes, sir.
Thank you, Dr. Rajesh. Yes.
Sir.
Steroid priming is required or not for stimulation test?
Yeah, it's a quite debatable thing. Some centers follow, some centers doesn't follow. The reason being, so the olden days they got lot of rules because the supply was restricted. They wanted to put hurdles at every stage. So the reason being at 10 years he is coming, you are presuming that when he becomes 14 he will gain the height. What will he do for next 2 to 3 years? So when we learned, yes, we learned it as a priming, but in practice we are not doing it. Yeah, no, I'm telling that's what. In training you learn.
First from institute.
See, it depends. As an academic workup, you tick it. If you are in academic, you are comfortable in your center. Otherwise, it doesn't add any usefulness to the patient. Yes.
One small comment, if I can,
yes.
with the permission of the chair. One is to just answer in the words of Ron Rosenfeld, who came to Chennai for discussing the same question, whether you will prime or not. If you want to treat the child, don't prime. If you don't want to treat with growth hormone, you prime. This is what he said, and they have done priming even in 3-year-old, 4-year-old studies are there. If you prime, the growth hormone peak will come, and you will say the patient is adequate. So if you want, that is one way. And the other one is the recent one Canadian expert speaker. She was part of the trial on this Pfizer's Somatragon. She came again to our department to give the lecture, and as sir was pointing out, now only in India, there are some other alternative growth hormones which are relatively costly, but now they are affording. Some people are out of pocket also giving. In the last 2 decades only, our usage on real deficient patients are almost like universal now. And now suddenly they bring this long-acting and say it is costly. For that, she said the stakeholders are to be included in decision making. For example, as sir was pointing out, in Canada, US and all, many patients, parents complain that, you know, the child is complaining of pain. And then I said, in type 1 diabetes, you are pricking 4 times a day, and there also most of the children don't miss the doses. And why will some child, as sir was pointing out, no child will miss the dose in India if you see the growth. Then why do you bring this? For which there was silence, was the eerie answer I got from her. And obviously there is a clear-cut marketing force and behind all this, and in the name of science, it will get propagated, and in these kind of discussions, we will be repeating the same.
Yes. Yes, that's true.
So 2 companies, there are no growth hormone Delhi. We are still surviving on the growth hormone which is coming from China. So when this Sun introduces their long-acting growth hormone, they will also remove Delhi. So where is Delhi growth hormone? Novo has removed, Pfizer has removed, so there are no Delhi growth hormone available.
Yes.
Yes, absolutely. Only GHD is approved. All other conditions are yet to be approved.
Yes. That's a crisis basically. It happened to all our GH deficient patients because all on a sudden it disappeared. And also the volume, if you see 0.66 milligram per kg per week, you are injecting so much at a time, and that may be injection site reactions, because even with a child who is overweight, the per kg, even daily at times we give this problem. So I think probably that is one of the hindrance, and also long-term study is not there. And also non-GH deficient, yes.
Yeah. So regarding volume, we have carried out these trials with all these 3 long-acting. Not a problem. You inject on Saturday, there may be some swelling for Sunday and then disappear by Monday. That's not a problem if child is growing. So we can use long growth hormone, but we are paying extra. And these are patented technology. These are not patent-free technology. So money is going there, and if daily growth hormone is available, there is non-inferiority. We can use that. We will be paying less money. But unfortunately, we do not have any of these growth hormone are being produced in our country.
Dr. Ganesh, regarding the peaks and troughs and the concerns with the adverse effects, so how high do the peaks go and how low do the troughs go?
Yeah, actually the IGF-1 we are supposed to monitor, it can go up to more than 3 SDS also. If it is like that is the reason probably it is better to start with a slightly lower dose. Even though the Somatragon they say the 0.6 milligram per kg per week. So we can start with probably 0.5 milligram per kg per week, and if the child, their cost is the issue, probably we can slightly lesser dose also, and assess the growth and then decide. So if the guidelines they clearly say IGF-1, if it is more than 2 SDS, you reduce the dose by 15%. That's what they say.
Another interesting case reports, couple of things I read is if you are testing HCG for some other reason on a patient who is on the somatrogon, it may be falsely positive. Pregnancy UPT will be positive in the children who are if you are testing. Yes, after all, that molecule is attached to it. It's
okay. Interesting. To Dr. Vagesh, so the pitfalls, potential. So if you, for the students, you want that, we usually what we do, 2 tests. So first test, if it is a positive and you have the physiological, everything is so still we advise for the second test. Yes, first test you do as clonidine, and then also second test you.
Some of the clear-cut cases, I think 2 tests will not be required. Only. Sir, see, the 2 tests is required in only a small number of cases. Single test is enough in many cases, what we see by the time they come. So where we are not convinced with a single test to administer a treatment, no, there probably the 2 tests are required. So now with IGF-1 we are doing screening, and clonidine we are doing, probably rarely we are going for the next test. Yeah.
Just a small question regarding measure IGF-1 only condition where we can reduce doses, IGF-1 is going more than 1 standard deviation above the mean. That's the only, which will never happen in our condition because we start lowest possible dose because of the cost reason. And all clinical trials, they are research trials, so they will measure IGF-1 every week. That's not a problem. But for routine management, like in my patients, we hardly ever use IGF-1. And even if we use IGF-1, it's freely available in our institute, so we can measure IGF-1. They have to give one sample, that's all. But otherwise, in practice, not required to manage IGF-1. Why to measure
baseline
IGF-1?
maybe at baseline or maybe
No. Once we have started treatment, after that maybe once a
Once
year,
in a
just
year
to
or 6
indicate
months,
that
yes.
we are not treating from very high dose, which will never happen.
One last question to Dr. Kumaravel. Juvenile idiopathic arthritis, when whether growth hormone, you have spoken about the biological agents which also cause increase in the height. But if you start growth hormone, is it you do a test for this or you just, what is recommendations basically?
Basically, what is the recommendation, what they have said is, when you control your inflammation with your biologicals, and when your disease activity and inflammation comes down, naturally you can have your catch-up growth also. In spite of your biologicals or in spite of whatever drugs you have been using, you are not able to achieve your adequate height, and still you feel your inflammation and your disease activity is less, you can consider growth hormone for these patients. Still, the recommendation is not very clear what exactly has to be monitored, because many of these patients, your growth hormone is normal, they have some kind of growth hormone resistance kind of stage in these patients. So that's the reason they say even the growth hormone recommended, even if you want to use it, is slightly at the higher dose. We still don't have a guidelines what exactly has to be done, because since it's an off-label indication, it has to be done only when all these things is controlled, but still you want some amount of height. You have to explain to the patients regarding the side effect, especially when you have limb length discrepancy, it can aggravate your discrepancy in this patient, and especially your skeletal complications with growth hormone are much higher. Slipped capital femoral epiphysis is very higher. So we should be very careful in using growth hormone in these patients.
Sir, in that case, if we residents get any referrals from rheumatology, you often get referrals from rheumatology regarding that patient has GIA, so what to do. So what will be your take? That they are rheumatologists, they are known to well control the disease.
So in this case, probably what basically we see is many of the rheumatologists refer to us, but they don't control the disease process at all. We are looked as a buffer for them to push the patients to us.
Yes, sir. So what do we mean by disease control? Is it normal ESR, normal CRP, or something like that?
So there are three things which are, one is the clinical parameters, what they look at, whether your joint pain and other things comes down. They look at your ESR, they look at the CRP. So these are the three things what they monitor. But what I have seen is many times when they come to us is, the rheumatologists really don't want the height to be improved, but they want the patient to be shunted out to someone. So that's how we are used. That's what happens.
Thank you.
They improve.
Thank you. I think we have had a very excellent discussions and talks. So I think we could close the session now. Thank you so much. Thank you all the speakers and Chairperson, Madam.
So thank you the respected chairpersons and the respected speakers. From growth nuances, it is time to move on to disorders in sexual differentiations, that is updates in DSD. To chair this session, I would like to call upon stage Dr. Sudhir Ranjan Pattonayak sir, who is a former head and professor of Department of Endocrinology at SCB Medical College, Cuttack, as well as Dr. Satyaki Manna, who is a former faculty member of RGKR Medical College and Hospital and consultant endocrinologist at Sevabroto Super Specialty Hospital, Howrah.
Manage it. Amongst the different steps that we take in the management, one fundamental fear remains. The fear looms over us as a Damocles sword. Is my patient going to develop malignancy? So we will be discussing more about this, and for this I am inviting Dr. Raju A. Gopal, who is a DM from KEM Hospital, Bombay, and is now an associate professor at MES Medical College, Perinthalamana, Kerala. Dr. Gopal, please.
Thank you, chairpersons. Good morning to all of you. And outside, I thank Sadhukhan Scientific Committee for giving me opportunity to present before you. This is a very specific topic, as chairperson already pointed out. Tumor risk in the disorders of sexual differentiation. What have we learned over the years? So in next 20 minutes, I will be trying to present what are the basic pathophysiology behind this, what are the pre-malignant conditions, and what are the screening tools we have, risk stratification in each DSDs, and treatment, especially the gonadectomy, timing of gonadectomy, and what is the way forward in this scenario. So before going to the topic proper, DSD is a group of disorders, congenital, which are chromosomal, aberrations in chromosomal, gonadal, or anatomical sex development. And the clinical spectrum can vary from simple genital anomaly to complex systemic involvement as well. And germ cell cancer development is a very important development in this scenario. We will be discussing about it next slides. So pathophysiology, there are many known risk factors for this. But if a single determinant point or single major risk factor would be the presence of Y chromosome, that is the testis-specific protein, the TSPY, in the Gonadectomy loci of Y chromosome. Origin of these tumors are basically from the primordial, pluripotent primordial germ cells, which are either non-mature and non-transformed, undifferentiated. These are the origin of these tumors. And second important risk factor is the presence of OP3, 4, along with TSPY would be the second most common risk factor. And third would be the stem cell factor. Stem cell factor, ideally the role of stem cell factor is in the embryonic period for the transport or the migration of the primordial germ cells from the yolk sac to the developing gonadal ridge. And its effect is supposed to be weaned off by the embryonic period, which remains, the expression is still there, the post-embryonic period. It is considered as a very high risk factor. Now coming to the pre-malignant lesions, there are two pre-malignant, known pre-malignant lesions. One is gonadoblastoma and second is germ cell neoplasia in situ. The previous name was carcinoma in situ of testis. So gonadoblastoma is a mixture of germ cells and sex cord stromal elements. These are pre-malignant neoplasm which have progressed to seminomas or dysgeminomas over the time. And again, it is exclusively seen in these genetic gonads, which contains the GBY loci of Y chromosome. And usually it is not metastasizing, but only thing when there is a left untreated, it can develop into, at least in 50% of time, to invasive germ cell tumors. Now germ cell neoplasia in situ is the second one. It's also a transformed but non-invasive. It's a precursor of germ cell tumors, and it is usually found in the testicular tissue of the DSD patients, especially with Y chromosome, presence of Y chromosome. Seminomas and non-seminomatous tumors are it's a precursor for seminomas and non-seminomatous germ cell tumors. This cartoon, which expresses and implies that the risk of GCC in DSD, what is the importance, the relation between the function as well as the tumor risk. So bipotential gonad, as we know, through the undifferentiated gonadal tissue, matures into normal testis and ovary in females. And once it's not maturing to the normal thing, it's undifferentiated, the chance of risk of GCC is high, where the function will be less. So normal functioning testis and ovary have minimal risk, while undifferentiated has higher risk. This is the relation between the functionality and the risk of tumor. Now coming to the screening tools, we have 4 or 5 screening methodology by which we can follow the patients. One is the self-palpation, which can teach the patients, but the problem is may not be of great use in most of the patients, and the remaining are the imaging, tumor markers, microRNA, and histopathological and biomarker assessment. So imaging, the most commonly and widely used are ultrasound, which is sufficient in most of the cases, except in a few cases where you require a much more soft tissue detail, probably MRI may be of use. The problem, whatever modality you use, is these are very less sensitive to pick up the malignant changes. So it has to be clinical utility, may not be of great in this, but this is what we have. And next is the tumor markers. The use of tumor markers is like what you see in the general population. So classical things are LDH in dysgerminoma, alpha-beta protein in yolk sac tumors, beta-HCG in choriocarcinoma and some seminomas. But again, many tumors may not be secretory, and you may miss them. And a review by McCann and Crosby in 2014, they suggested that they concluded that there is a poor evidence and unknown implications for the screening these patients with in DSD with tumor markers. Now, microRNA is one new tool has coming up, which is found to be increased in testicular GCTs earlier. Now, recent data suggests there are many other tumors also might be producing microRNAs, and in the serum, if you measure, you get able to get a good specificity, with a good specificity and sensitivity of more than 90 and 86 respectively. And future, it could be serve as a good method for screening as well as surveillance. The only problem, the premalignant lesions may not have adequate secretion. So you may miss a premalignant lesion with this thing. Only invasive tumors will have adequate microRNA secretion. Now the gold standard would be the precursor definitive biopsy and with histopathological immunohistochemical markers, which are OCT3 and 4, PLAP, CKIT, and SAL4 and TSPY. These panels, if you use, you can come with good, probably good rate of picking up for malignant changes. And FOXL2 is once is supposed to be seen high in sex-core stromal tumors. Now coming to the risk stratification in individual DSD. So 46XY DSD, complete gonadal Swyer syndrome, carries the highest risk of developing tumors, and of which most of them develop in by the second decade. Almost 2/3 of the patients will have tumor risk, and most common ones are gonadal and dysgerminoma, and early bilateral gonadectomy is indicated in these cases. Partial also, the risk is not as high as complete, but still it's about 15 to 30%. And here also, close follow-up or early bilateral gonadectomy is the recommended treatment. Coming to different set of disease, that is androgen insensitive syndrome, where you can have a partial as well as complete. And the complete androgen insensitivity, the chance of developing tumor in the pre-pubertal period is extremely low, and post-pubertal also it is not that high, and that they are mostly non-invasive. So current surveillance studies suggest that gonadectomy after the puberty, so that the secondary sexual characteristics are developed well. Also, you allow the bone accrual, which happens in the pubertal period. So that also help in, and if you defer the gonadectomy post-puberty. Partial has much more than the complete, but still that also is not that high. There also, the recommendation currently is to wait until the puberty is over. Mixed gonadal dysgenesis and mosaic karyotypes are a different set of diseases, and their malignancy risk is reported varying in various studies, and is more than 50% in some studies. And here the recommendation is to treat according to the individual scenario. And the streak gonads, which have very low germ cells, may not be of high risk. Over-testicular DSD is another set where you have both ovarian and testicular tissue, and tumor risk is again variable. Very varied report, up to 20% is reported. Most commons are gonadal and seminomas. But the thing is that fertility potential has to be taken into consideration when you treat over-testicular DSDs, and decision should be made balanced between the potential for fertility as well as oncologic safety. 46XX DSD, which includes congenital adrenal hyperplasia, though they are very virilized gonads, but their risk of developing tumor is extremely low because of the lack of Y chromosome, and no gonadectomy is required. So this is what nutshell we discussed: Swyer syndrome, partial total, and the partial XY dysgenesis, high risk of developing tumors. Early gonadectomy is recommended, while androgen insensitivity, post-pubertal risk is in partial is 5 to 15, complete less than 2. So post-puberty gonadectomy is recommended. Over-testicular, depending on the scenario, and congenital adrenal hyperplasia, you don't require any treatment. This is how the individual thinks. Whenever approach is looking at the clinical diagnosis as well as the clinical presentation. So suppose a 46XY DSD or a mixed gonadal dysgenesis is a male phenotype. These are gonads which allow them to have spontaneous puberty. And most of the time, sperm production may be less, but these gonads are not, the risk of gonadal malignancy is relatively less. And the early biopsy is not required in most patients unless there is any specific features for that. Then you do orchopexy for the abdominal and inguinal gonads. Then afterwards, self-examination and annual ultrasound. End of puberty, do a biopsy along with testicular sperm extraction if possible. Because the ambiguous genitalia, this gonad is more likely to be more dysgenetic and tumor risk is relatively high. So in such cases, you should do a biopsy on the first itself, inguinal and abdominal gonads, and orchidectomy if you found to have any premalignant lesions or undifferentiated gonadal tissue. If not, bring down to scrotum and self-examination with plus annual ultrasound until puberty. And puberty, you do a biopsy and sperm extraction possible. Female phenotype means to say this gonad is not working and this is dysgenetic completely and the malignancy potential is very huge. So better to do a gonadectomy at the diagnosis or before puberty. And second set of diseases like testosterone biosynthetic defect or androgen insensitivity or over-testicular. Here also, if it's a male gender, the tumor, the gonads can be brought down by orchidopexy, self-examination, annual ultrasound, and if it's an over-testicular DSD, selective removal of ovarian tissue. With a male gender, ovarian tissue can be taken out. Ambiguous presentation, especially partial androgen sensitivity and testicular biosynthetic defects, what happens here is that the gonadectomy has to be done to avoid the virilization in the later life, but this has to be done once the gender identity is fixed or it is well formed. In complete androgen sensitivity, as we mentioned, no requirement in the prepubertal period. And over-testicular, it is better to remove the testicular tissue in patients. And if gender identity is not fixed, it's better to delay the puberty using GnRH analogs. Two other scenarios worth mentioning, not exactly gonadal tumors, are one is Klinefelter syndrome, where they don't have gonadal tumors, but their mediastinal GCT and breast cancer incidence is more. But not being a gonadal, there's no need for orchidectomy or gonadal removal of gonads. Second one is a persistent Mullerian duct syndrome, where previously the remnants were to be left undisturbed. Now there is emerging data to suggest that there is an increased risk of Mullerian malignancy. So this has to be discussed, and if required, it has to be removed along with the orchidopexy. So considering prophylactic gonadectomy in these four situations, when 46XY, complete or partial dysgenesis, debility-associated syndrome such as Denny-Dash and Frazier syndrome, streak gonads with Y chromosome, and a documented premalignant lesion where the gonads are intra-abdominal, you don't have a reliable method by which we can screen these patients, and so better to remove in such patients also. The conditions where you favor surveillance are, one is androgen sensitivity, second is biosynthetic defect, and third is over-testicular, especially without a Y chromosome element. And when you are planning a surveillance, you should look at the things which you already mentioned at the baseline, the location of the genotype, location of the gonads, and periodic ultrasound imaging, tumor markers, and at follow-up also you have to do the same thing, tumor marker measurement, periodic ultrasounds, self-examination, and a very low threshold to keep to re-exploration in such if any finding change happens. And biopsy is required with the immunohistochemical markers when there is a sudden hormonal change or there is a imaging change, rapid size increase or any other changes, or a pubertal transition in intermediate risk groups with these histochemical markers. Now, gonadectomy is the most important decision, as I mentioned in the first slide. As far as DST is concerned, you have to consider the risk of malignancy, psychosocial elements, and the hormone production, of which the most important one is the risk of malignancy. And the timing of surgery depends upon the genetic diagnosis, and which will predict the risk of malignancy. Three major risk factors for development are, one is genomic constitution, that is the presence of Y chromosome, GBY locus of Y chromosome, expression of embryonal germ cell markers beyond 1 year, and third, the anatomical location, intra-abdominal location. These are the three major risk factors. And the current practices as far as gonadectomy is concerned, to involve parents and possibly patient if enough old, to involve in the decision making, and families should be counseled about the cancer risk, fertility potential, and psychosocial implications, and delay the gonadectomy in patients such as complete androgen sensitivity to allow the development of secondary sexual characteristics. Also, if you have an ambiguous presentation, difficult to make decision in a low risk category, wait until the puberty is over so the patient preferences also can be entertained. And what you require is a multidisciplinary approach for the better outcome involving endocrinology, urology, oncology, and psychologist possibly. And what we lack is we don't have a precise age-related risk curves in each DSD, and optimal surveillance protocols are not yet formed. This is, as expected, this is very small number of patients. We don't have a large prospective multi-center registries from the world is not available. So that is one problem. Many times we have to take a decision depending upon each scenario, and you have to be very careful with each patient you are seeing and make an individual decision. What is the prospects are? And novel biomarkers, liquid biopsy approaches, and organ-sparing techniques may hold promise for the future protocol formation. So with this, I end my presentation. Thank you for your patient hearing.
Nice presentation. We'll please wait. We'll invite the second speaker in this session, and for this, I will invite my co-chair, Dr. Mana, to take over.
Thank you, sir. Dr. Joyashree Gopal, Senior Consultant Endocrinologist and Diabetologist, Apollo Hospital, Chennai. Also Vice President, Endocrine Society of Tamil Nadu and Puducherry. I invite her for her deliberation on genetics in DSD in resource-restricted setting. When and what? We know even our best physical examination and biochemical test, in some DSD patient we can pinpoint the diagnosis, and in that case the genetic analysis is essential. There are so many genetic tests that are available. They have different types and cost, and all the tests are not available in every part of India. So which test should be done at what time, in which method she should discuss in her talk. To Dr. Joyashree Gopal, please.
Good morning, respected faculty. Thank you to the Endocrine Society of India and Endocrine Society of Bengal for this. Thank you, sorry, I'm just for the invitation and the hospitality. So this is the title of my topic, Genetics in DSD in Resource-Restricted Settings. And we heard a very nice talk from the previous speaker about the necessity to, for example, pick up the Y chromosome because of the risk of malignancy or Y chromosome material. And as was discussed in the previous slide, it is a very heterogeneous group of congenital conditions. We are beginning to understand more about the genetic etiologies and the various types of differences in sexual development. And early and accurate diagnosis is necessary, obviously not just for the optimal medical management, but also to provide adequate psychosocial support and to determine gender assignment in an informed manner. And of course, genetic testing is critical in our country in resource-limited settings, but there is a lot of genetic work which is being done, and I shall go through the tests that are available and some of the data that has been available from India in recent times. This is the classification, again, as was shared earlier. You have the 46XY DSD, which occurs either because of problems in gonadal development or androgen synthesis or androgen action. For the most part, I'll be just restricting the genetic testing to these. 46XX DSD, again, either problems with gonadal development or most common reason for 46XX DSD is the various forms of CAH. And then, of course, we have the sex chromosomal DSD, the Turner and the Turner variants, the Klinefelter and its variants, and the mixed gonadal dysgenesis. if you look at the various studies from different parts of India, the most common diagnosis across various series tends to be 46XY DSD. This accounts for around 50 to 60% of cases in most series. This is followed by 46XX DSD, and this accounts for about 40% in most centers. And then the sex chromosomal DSDs account for about 10 to 15% according to the published data. And within each category, for example, if you take the 46XY DSD, it's about evenly distributed between androgen insensitivity and 5-alpha reductase deficiency. And as I shall discuss, biochemical diagnosis, clinical diagnosis tends to change a lot when you actually get down to the genetic diagnosis. So whether these numbers will hold up the more we do genetic testing, we have to wait and see. And then of course 46XS DSD, in a way it is simpler because most of the cases occur because of various causes of CAH, whether it be the 21-hydroxylase deficiency, the 11-beta hydroxylase, or the 3-beta hydroxysteroid dehydrogenase defects. So this is easier to determine what genetic testing to use. These are the various genetic tests that have been used commonly in DSD, and I've just listed them in order of what segment of the chromosome they're looking at, what percentage of the chromosome, and to what extent, to what depth are they looking at across the chromosome also. And we'll talk a little bit about each one of these tests in the next few slides. Karyotyping is always the first line. We cannot do without it, obviously. With karyotyping, you can find structural changes if it involves at least 5 million to 10 million base pairs. So you need a large segment of the genome to be affected to be able to pick up changes using the karyotype. And this is enough for picking up the common types of, say, Turners or Klinefelters, and karyotyping is a good and a necessary starting point. You have to talk to the lab to ask them to look at least 50 metaphases so that you can pick up mosaicism, if not more, and you need to have a good relationship with the genetic lab to be able to pick this up. When we ask for a karyotyping, what is generally done is what is called the standard G banding, where you pick up 400 to 550 bands can be visualized, and that is typically enough to determine whether the chromosomes are properly aligned and whether the size is okay for the most part. This is adequate, like I said, for the most common Klinefelters, for the most common, say, Klinefelters or Turners with mosaicism, which is available, but keep in mind that a karyotyping may not be enough to pick up low levels of mosaicism. So if you have less than 15% of the cells having a Y chromosome, it may not be able to be picked up with a karyotyping, which is where the next set of tests becomes important. So for example, let's say we have a 46XY child, which is under-virilized. We know that there is a problem either with the gonadal development, androgen synthesis, or androgen action, so androgen resistance. There are a number of genes which are involved in gonadal development. You can see that even for the formation of the bipotential gonad, you need all of these genes, the NR5A1, the GATA, and the WT1. So these are necessary even for the development of the bipotential gonad. This has to be followed by proper expression of the SRY gene, the sex-determining region of Y, followed by also expression of the SOX9. So you need a number of genes acting in concert to determine whether that bipotential gonad is going to go on to form a testis or whether it is going to go on to form an ovary. But the presence of Y is important, as you heard in the previous talk, because this is the one that most critically determines whether there is malignant potential in that gonad. So to determine whether there is Y chromosome material present, what is recommended is a FISH, so SRY FISH is what we commonly do along with the karyotyping, or a PCR for the SRY gene. And I'll talk a little bit about the difference between the two. FISH is, of course, fluorescent in situ hybridization, where you make a fluorescent probe that binds to the SRY region, and you'll get a picture which looks like this. That tells you not only the presence of the SRY gene, but also the location. Is it present on the Y chromosome? Has it been translocated somewhere else so that it cannot function? So you get both the presence and the location of the SRY gene using a SRY FISH. The test, typically, we use it because the turnaround time is very quick. It is 24 hours, usually in most of the bigger centers. It costs around, somewhere around, depending on the lab, somewhere between around 2,000 to 3,000 rupees, maybe less, depending on each lab. One thing it cannot pick up is, it can tell you the location and the presence, but it cannot tell you whether it's working properly. So if you have a single point mutation in the SRY gene, that cannot be picked up with an SRY FISH. So to pick up single base pair defects, which means that the SRY protein is not being made. You actually need to go on to do a SRY PCR, which is a little bit more. It takes a longer time. Cost is relatively okay, but it is something to keep in mind. The SRY is present, but there is still no testicular tissue. It may be related to some problem with the SRY gene itself. When should we add SRY testing, FISH or a PCR? Urgent sex assignment in newborns, or quick sex assignment in newborns. So it gives faster results, 24 to 48 hours, than the conventional karyotyping, which typically takes 7 to 10 days, if not longer. If you have an ambiguous or a mosaic karyotype, if there is any doubt, I think it's always good to anyway include a FISH for the SRY to make sure absolutely that we are not missing any low levels of mosaicism. And of course, the other typical evaluation would be a 46XX, but the phenotype is male or virilized, or 46XY, but no testicular tissue is detected. Obviously, the starting point for further genetic evaluation is to establish the presence or the absence of the SRY gene. Now, moving on to the next set of tests that is becoming more and more widely used in pediatrics, particularly in various types of genetic issues, it's the chromosomal microarray. So what the chromosomal microarray does is it looks at copy number variation. So you have a particular segment of the chromosome. Is that segment preserved? Is it duplicated? Is it deleted? Do you have extra number of copies? The chromosomal microarray looks at larger segments of the chromosome. So it can look up to roughly around 10,000 base pairs. So larger chunks of the genome can be looked at. And the way it is done, there are two ways of doing it. One in which the patient's DNA is labeled with one particular fluorescent dye. The reference DNA is labeled with another dye. And these are hybridized onto a chip with thousands of DNA products. And looking at the relative fluorescence, you'll know how much of the gene product is present. Is it more? Is it less? So that is what a chromosomal microarray would tell us. This is what the report would look like. So you can see that there is some change here. There is somewhat of a little spike here. And this is an example of a published paper on a SOX9 duplication. I'll talk about that in the next slide. But nowadays, chromosomal microarray is becoming important for pediatric diagnosis, for developmental delay, autism spectrum disorders, congenital anomalies, and for, of course, DST workup. We can use it more commonly. You need just the DNA from blood. It takes about 7 to 10 days, and the cost, I'm basing this on the other pediatric diagnosis. I've not seen a specific recommendation for a DST, but typically it varies anywhere from 10 to 15,000 rupees. So let's say we have a 46XX karyotyping, but the child is virilized. Then you might need to think about a SOX9 duplication, and that is picked up using a chromosomal microarray. I just put this slide up again to remind you that the formation of the ovary involves not just the absence of the SRY, but also the absence. The SOX9 has to be turned off. So if a child has the SRY is absent, but the SOX9 is upregulated, it would still go on to develop as a testes. So this is the typical, in my days we used to call it the vanishing testes syndrome. And this was the first paper to describe the SOX9 duplication. They took these group of children, 16 SRY negative XX male children, and two of them or three of these childs had duplications in the SOX. And this was the paper which first established that the SOX9 overexpression can substitute for SRY in initiating male gonadal development. So, and this, picking up something like this, some chromosomal microarray is useful. So clinical scenarios where a chromosomal microarray may be useful in DST. For example, you have a 46XY karyotype. There are dysmorphic features. You need to think about a 9p24.3 deletion. Or you have a 46XX, this I spoke about, but a virilized child, then you need to think about a SOX9 duplication. Another one is ambiguous genitalia with developmental delay. You need to think about a XP1 deletion. So there are various clinical situations where you can decide where a chromosomal microarray is going to be the best test to pick up these specific genetic testing. Let's say it's a 46XX virilized child and your biochemical workup has shown CAH. Then you need to move on to the next set of tests, which would be the MLPA and the allele-specific PCR. So I'll talk about the MLPA next. This stands for multiplex ligation-dependent probe amplification. What it does is it looks at the same similar to what the chromosomal microarray does, copy number variations, but you're going closer down. You're going into the level of the exon. You're going into the level, each gene is made up of many exons, so you're going deeper down. You're focusing more. So copy number variation in specific genes or exons is looked at, but for this, in general, you need to know the mutation that you are looking for, because then only you'll be able to set up this assay. The resolution is very high. You can go down to 100 to 200 base pairs, and a recent study, for example, published from the CMC Vellore group, showed that this was used very successfully in detecting mutations in the CYP21A2 gene in a series of children with CAH. The cost in other situations works out to about 10,000 rupees. This is what a typical report looks like. If you have 2 functioning copies of the allele, you're going to have a value of 1. In this next slide, you can see that this child has this segment of the exons missing. So this is one type of a CAH, so one allele is completely mutated. MLPA is also useful to pick up what are called compound heterozygotes, so different mutations on each allele. This can also be picked up in using this MLPA technique. Generally, the MLPA is combined with something called an allele-specific PCR. So in allele-specific PCR, you need to know the specific mutation. So what it does is, it detects known point mutations. So it uses primers that bind only if the specific mutation is present. So amplification of the genome or this amplification of the gene product only occurs if that specific mutation is there. So the more we do genetic testing for the DST children, the more we'll be able to get India-specific data and be able to do allele-specific PCR. Why is it necessary to pick it up? Is it going to alter our clinical management? And it is important because the mutation type, whether it is null or a mild type, predicts the phenotype, whether it's going to be a salt wasting, simple virilizing, or a non-classical. Severe mutations will need stress doses of the glucocorticoids, mineralocorticoids. Mild forms need less intensive therapy. Importantly, genotyping allows for carrier detection, recurrence risk estimation, and prenatal diagnosis. Biochemistry alone cannot ideally differentiate between chimeras, deletions, or distinguish what the case that I presented, the compound heterozygosity. So it is important in that situation to be able to determine exactly what the mutation is in CAH. Now finally, I'm finishing up with the most elaborate set of tests, the next-gen sequencing, where you basically go down to the level of the genome and sequence all of the bases present. You can have next-gen sequencing just targeting some genes, or you can sequence the entire exome, or you can sequence the entire genome, including the exons and the introns. So that is the most advanced version. Obviously, these are more detailed, and for this, we need a lot of material about the population, because these are all, the output is obviously compared against the baseline population, so it is very bioinformatics heavy. We are doing whole exome sequencing for a number of other conditions like for example, MODY, but then we just get back reports saying variant of unknown significance, and we are not sure what to do with a report like that. So we need to go through a period of gathering more data before we can establish proper protocols for using these tests. However, this is an example of a NGS using a 50-gene panel for DST. This is from a published paper from Italy. So you can look at all the genes that are included in this panel. For example, the GATA4, the HSD, 3-beta2, and so on, the NR5A1. So you can set up, if you know what are the common gene mutations in your population, you can set up a next-gen sequencing, targeting a number of, say, 25 genes or 50 genes. You can set it up, and it becomes a relatively cost-effective method to quickly screen these children for these mutations. Two recent papers, one which just came out last month actually, jointly done between JIPMER and CMC Vellore. 37 children with 46XY karyotype with a EMS score of less than 10, provisional hormonal diagnosis of 17-beta hydroxysteroid, 5-alpha reductase, or partial androgen insensitivity. They did a next-gen sequencing just targeting these 3 genes. So they looked at the androgen receptor, the HSD, and the 5-alpha reductase, the SRD gene. The one thing I do want to point out in this was that the concordance between the clinical and genetic diagnosis is only 22%. A large number of people who were diagnosed as 5-alpha reductase deficiency actually turned out to have androgen PACE, partial androgen insensitivity. So in this paper, it was pointed out that the testosterone to the DHT ratio was found to be unreliable for differentiating PACE and 5-alpha reductase 2. So it's obviously important to keep this in mind when we are interpreting genetic thing in this particular situation. So NGS is important. A similar paper which was published from KEM Hospital a few years back also did a next-gen sequencing in children, in 18 children, and they targeted 2 other genes in addition to the androgen receptor and the 5-alpha reductase relevant gene, NR5A1 and WT1. Again, in this paper also, they didn't specify the exact thing, but several mutations which were thought to have B5-alpha reductase deficiency turned out to have androgen receptor mutations, similar to what was seen in the previous paper that I mentioned. Obviously, this makes a key difference, as we are all aware, because the 5-alpha reductase will more often they have to be reared as males because they virilize as puberty. Gonads will be preserved and oculopexy will be done. They will need to be treated with testosterone or DHT, and autosomal recessive, so high risk among siblings. Whereas androgen insensitivity, female rearing is usually appropriate and gonadectomy is often required, followed by estrogen therapy. So this differentiation between partial androgen insensitivity and 5-alpha reductase deficiency, I think, is one of the key areas where genetic testing is going to be helpful, and maybe setting up NGS panels to look at this would be helpful in our country. What is the comparative cost? Again, these are based usually on tests done in other conditions for things. So you can see that the costs vary down from ranging from around 2,000 rupees for a karyotype to about, we can get like a whole exome sequencing for 15 to 20,000 rupees. If you talk with a lab, still it is not a very cheap thing, but you can go down, and I think as we use it more and more, hopefully these costs will come down. So to finish, I just want to quickly talk about what may be a clinically relevant approach, genetic-based approach to 46XX DSD, for example. If there is no SRY gene present, more likely to be a CAH. Once you've established a diagnosis of CAH, you can go down the MLPA or the allele-specific pathway. Look at the 17-OHP. If it is normal, think about SOX9 duplication. So all of this, you can do either a chromosomal microarray or a MLPA testing. If the SRY is present, then immediately turn over to the chromosomal microarray or the next-gen sequencing. Similarly, in a 46XY DSD, I think this is what is causing a little bit, the biochemical diagnosis does not seem to be as robust in differentiating between the various causes. So in this, I think we should give a thought to developing our own panels based on the local mutation patterns and going directly into a next-gen sequencing once you have a 46XY. It is a thought. Obviously, it is cost intensive, and we need to gather more data before this can become a recommendation. So to summarize, the genetic testing in DSD must be guided by clinical context and local patterns, and we start simply and then escalate. Definitely karyotyping, presence or absence of SRY, and then further going down depending on what we are suspecting. Mutation patterns present in our country should inform the first-line test selection, and cost-effective pathways are not just economical, they turn out to be clinically smart in the long term. And I'll finish here, and thank you very much.
Thank you, ma'am, for this lucid presentation. I'll invite you to join us in the dais, and I will also invite Dr. Gopal to come over and join us in the dais. Before we start the proceeding, Dr. Gopal, I want to start with you. Now, when you said that you have to, at the beginning, start consultation with your patient and the family, but the moment you mention the risk of malignancy, they becomes the entire picture changes, they get confused. For example, once a patient told me, patient attendant rather, sir, there is a case of CAIS, the complete insensitivity. Sir, if you believe that my patient may develop malignancy, why not to operate now? And why not you develop, try to, my patient to develop puberty with drugs? Why wait till the puberty?
In case of CAS, complete androgen sensitivity, the chance of developing prepubertal is almost negligible. It's as good as a very low level. Second thing, once you keep that over the gonads, the good thing about that, it will help in the secondary sexual characters will develop better because the source of steroids, sex steroids are there. Second, it helps in the bone accrual as well. At the prepubertal stage, the maximum bone accrual happens, so that period also will be can be served that also. And that statistics wise, CAS there's no confusion. Probably other scenarios probably have more confusion, but CA is a situation we don't have a confusion at all. I think we are very safe in advising them to do it afterwards.
Thank you. Now the session is open for any question, discussion, or comments. Yes, sir.
Thank you, ma'am. That was a very nice and lucid presentation on DSD. Okay. So you quoted our study from Kashmir, where we have found that it is the 5-alpha reductase which is more common. Rather, rest of our country has shown androgen insensitivity syndrome because of very good chance of cancer in our community. So 5-alpha reductase is the most common form of 46XY DSD. So how good are the currently available genetic tests for 5-alpha reductase? And if there is a hot spot in the 5-alpha reductase gene, which we can target?
Yeah, so I think the next-gen sequencing will pick it up. If you look at the study which came out from the CMC Vellore Tumor group, they did the NGS just using the 5-alpha reductase and if somebody is there, they can answer for it. So I think setting up an NGS panel, just targeting a small number of genes is absolutely critical in differentiating between these two conditions. At least in that study,
so NGS will be the best way to go.
Yes.
To differentiate from androgen insensitive 5-alpha reductase.
Yes.
Thank you.
Madam, how common is this copy number variation? So copy number, so I understand that when you do a NGS and you can only detect mutations, the copy number variation doesn't get picked up. So should we do that in every patient that is there? I mean, you need to do it simultaneously for a comprehensive genetic diagnosis.
That is why I put up a table. So some of the places where it's helpful is, for example, if you're thinking about developmental delay, syndromic features, there it's more likely that larger parts of the genome is affected. So the ones where there is a deletion of 9p21, where there is the DMRT1, all of those places. So clinically, you have to decide whether you want to go for a chromosomal microarray or if you're fairly certain it's androgen insensitivity or PACE, then you go directly for a NGS.
NGS also you do a limited panel. So whatever they've done in JIPMER, this study, they've studied only three genes. Not the 50 like in Italy.
No, not at all.
So any other questions from the house?
Good afternoon. This is less of a question, more of an answer to what Sir asked. Like, I've had some very little experience with genetics, so I can say that these days whole exome can pick up a lot of CNVs, sir, especially in case there is a deletion or a duplication that has been picked up and it crosses a particular length, then it may be prudent to go ahead and validate it on a CMA. That is what I...
What will be the cost?
So you'll have to do it again, ma'am. So back in, there is about 3 years ago, a whole exome would cost about $12,000, like up north, and now it's down to 7,000, and CMA is still above 10,000. So anywhere between 10 and 15.
It's pretty good.
So any other questions from the house? So I think the session has been overwhelmingly good, so that there is pretty fruitful discussion here, sir. So over to you.
Thanks to both our speakers. Very good presentation, nice program. Thanks to all of you. I am closing the session now. Thank you.
And thank you to the respected chairpersons for excellently chairing this session, as well as the respected speakers. As we are going towards our last session, like we are going from DSD to almost the last session of the day in this hall, for which I would like to call upon stage Dr. Dr. Ananta Raman sir, consultant endocrinologist and co-founder at Magna Center for Obesity, Diabetes and Endocrinology, as well as Dr. Sandeep Kumar Mittal sir, who is a consultant endocrinologist at Sohana Hospital, Mohali. So, So, pardon that. So, sir is from AFMC. So, pardon me for that. So, I think that much I can expect, right, sir? So, thank you, sir. So, the session is open for you, sir.
Our first speaker is Dr. Sushil Jindal. He's an ex-professor and head Department of Endocrinology, People's College of Medical Sciences, Bhopal. And he has done his DM Endocrinology from PGI Chandigarh, my alma mater. He's written chapters in RSSDI textbook of diabetes. He's got 36 publications in peer-reviewed journal. Former chairman, RSSDI Madhya Pradesh chapter. Editor, Diabetes Patient Education magazine in Hindi, which is called Madhumeh Vani. He was organizing secretary, ECON. So, sir is going to talk about CDGP and hypo-hypo. Is it worth differentiating the two and how to go about doing it?
Thank you, chairpersons, and must thank the organizing committee for inviting me here. So my topic is, they have made it some fancy name, fruitful or futile, constitutional delay in growth in puberty, which we keep on seeing very regularly in our clinics, versus hypogonadotropic hypogonadism. Now we know that delayed puberty is a big enigma and emotional and social distress for any adolescent as well as to their parents. There are two major conditions which has to be differentiated. They are CGDP and congenital hypo-hypo. Now distinguishing between these two may pose a diagnostic dilemma, and sometimes it's very perplexing for us to come to the correct diagnosis, because both present with almost similar sort of a clinical picture. And we should remember that CDGP is one of the commonest of the diagnosis, and nearly 2/3 of delayed puberty seen in males is because of CGDP, and 1/3 of delayed puberty seen in female or the girls is because of CGDP. So first diagnosis always is towards CGDP, unless there are some clinical clues. Now we should remember that before jumping onto the diagnosis of CGDP or the congenital HH, we should rule out the other possibilities, and the commonest other possibilities are hypergonadotropic hypogonadism and Klinefelter syndrome, anorchia, mumps, orchitis in childhood. And this is common in males, and in females, Turner is also very common. So we first exclude the possibility of hypergonadotropic hypogonadism, and then another common cause of delayed puberty may be functional hypogonadism, and this is usually hypogonadotropic hypogonadism. This may be chronic illness. We know that our type 1 children usually have short stature and also delayed puberty because of poor metabolic control. Malnutrition because of celiac disease or sometimes anorexia nervosa can also produce delayed puberty. Now this is a time when adolescents are very, very keen to have some fitness or some bodybuilding type of activities, and excessive exercise can also delay the puberty. And certainly we have seen children who have lost their parents during COVID and they are not going into puberty. So emotional stress also is a big problem. These are all functional, and there is nothing much to be done. You have to treat the basic condition and they try to go into puberty. Now other endocrine diseases have to be excluded: hypothyroidism, hyperprolactinemia, craniopharyngioma, Cushing's disease, and combined pituitary hormone deficiencies. And as endocrinologists, this may not be very difficult for us. Now this is a slide showing you that delayed puberty is fairly more common in male children or boys as compared to the girls. And if you see the purple color bar here, you can imagine that in 2/3 of cases in boys, it is because of CGDP, and almost 1/3 of girls, it is because of CGDP. Then come the functional causes and also the hypergonadotropic hypogonadism. So this is the split up. So in males, you are more likely to make a diagnosis of CGDP as compared to in females. Now, what is the definition of delayed puberty? We should be very clear that in girls, the first physical sign of onset of puberty that is puberty, is transition of tenor breast stage 1 to stage 2. And in boys, the respective marker for change is change of tenor genital stage, G1 to G2 stage, and that is achieving the testicular volume of 3 ml or testicular height of 2.5 centimeter. So this is the first clinical sign about the initiation of puberty. Failure to achieve these signs till the completion of 14 years in the male child or 13 years in the age completion of 13 years in the female child is considered delayed puberty. But also remember that development of pubic hair or axillary hair may not be a sign of puberty, and this is more a sign of adrenarche, and this adrenarche can happen at least 1 or 2 years prior to puberty in many cases. Now coming to etiopathogenesis, CGDP is a benign and a common cause of delayed puberty both in male and female, and it's also associated with short stature. So it is a variation of normal development rather than a pathological process. Individuals with CGDP usually have delayed bone maturation and puberty onset, both are delayed, and ultimately these children, they develop puberty at a later stage. This delay may be 3 to 5 years, but ultimately they have full development. And what happens is that there is a family history of delayed puberty either in the parents or in the siblings, and it happens almost 60 to 70% times. And recently there are some genes also have been identified which actually trigger the initiation of puberty. And these genes take cues from leptin level and environmental factor and body fat, and all those things are described. But till now, we do not know any particular mutation which is responsible for CGDP. Now, etiopathogenesis of hypo. This is actually failure of HPG axis. The secretion or the action of gonadotropin releasing hormone GnRH is impaired, and hence the gonadotropins also remain low. Congenital hypo has genetic basis, and more than 50 genes have been identified which can cause hypo. And these genes may be involved in differentiation and migration of GnRH neurons, and these neurons migrate along the olfactory tracts. Synthesis and secretion of GnRH and coding of GnRH receptor itself. So in the next slide, we can see that there are all the genes which have been recognized, either in the differentiation of neurons into GnRH producing neurons, or their migration towards the olfactory bulb, or it may be because of impaired secretion of GnRH in the cytoplasm of the neuron, or even if the neurons are producing GnRH, the receptor for GnRH in the gonadotrophs may be absent. And so these are various genes which have been recognized, and there are many recognized, and you can have it's a whole big chapter there. Now, what are the clinical features of hypo? Congenital hypo is usually present, they usually present at the time of adolescence with failure to start puberty or arrested puberty. Sometimes they may have some initiation of puberty and then puberty stops there. They may have slower growth in the pubertal or just before puberty, and but may develop unicoid habitat later on. Now, typical history is that child till the 5th standard was growing as per the height of the other peers in the class, but after that other classmates, they started growing because they entered the pubertal growth spurt, and this child became shorter in the class. So this is the typical history which we get, and then this child will not develop any secondary sexual character, and ultimately because of the absence of sex steroids, what will happen is that some of them will develop unicoid habitat, and they may also become tall. So in subjects with HH who have Kallmann syndrome, and remember, Kallmann syndrome is seen almost in 50% cases of hypo, There may be anosmia, there may be midline defects in the form of cleft palate or cleft lip, and also synkinesis can be demonstrated. You ask them to do movements in one hand, the other hand automatically also moves. So this is synkinesis, and and when you do MRI, the olfactory bulbs may be absent in these cases. In infancy, male child may have absence of mini puberty. They may also have micropenis in the childhood, and also cryptorchidism. And there are reports saying that almost 30 to 50% of these children have cryptorchidism. So this is a common thing. You can ask them that child may be brought to the endocrinologist or the physician, the pediatrician, that the penis is very small looking. So that may give you a clue that child had consulted some pediatrician for small penis, then it's more likely to be a hypo. Female generally present with failure to enter puberty and primary amenorrhea. So females, you don't have any clue before the presentation. They usually have delayed either there is no development of secondary sexual character, or there is primary amenorrhea and no secondary sexual character. Now coming to clinical features of CDGP, the most subjects present with short stature, and they can present much before the timing of puberty. So what happens is that there is a deceleration of length and height in the first 3 years of life. So instead of going like this, they have first 3 flat years, and then they have almost normal growth velocity till the time of puberty. But what happens is they are missing their pubertal growth spurt, and ultimately they will enter puberty some 3 to 5 years later, and then they can have a normal adult height. Bone age is significantly delayed, and the chronological age is, the bone age is equal to chronological, the height age, but it's significantly delayed as compared to the chronological. There is a delayed pubertal growth spurt and delayed onset of puberty, and this delay may be 3 to 5 years, and development of secondary sexual characters may start very late. Puberty onset, once initiated, completes spontaneously, and child attains a near normal adult height, and according to his genetic potential. Now this is the red line here, if you can see, is the third centile line, and you can see here that initially child lost, before 4th years he lost some height centiles, and then he was growing 3 to 6 centimeter a year, and his puberty started something like 14 year, and then there was pubertal, and ultimately reached the same adult height which was expected of him. Now diagnostics is a really sometimes very, very difficult. Differentiating between the CGDP and HH in adolescent is sometimes challenging. A good clinical history examination and longitudinal follow-up may yield the diagnostic clues. Family history of delayed puberty in parents or siblings, which happens almost in 50 to 70, strongly suggests CDGP. Past history of cryptorchidism, micropenis is suggestive of hypo. History of short stature in child is more significantly seen in CGDP. And presence of anosmia, synkinesis, midline defects are diagnostic of Kalman syndrome, which is a very common type of hypo. Now, how to make diagnosis? We can have basal LH-FSH, but cutoffs are very often overlapping. GNRS stimulation test, then bone age, which is more likely to be delayed in cases of CDGP as compared to hypo. AMH, there are some new papers suggesting that AMH can also differentiate between, because AMH is a product, and this is more with the male child as compared to female child, because AMH is a product of Sertoli cells, and Sertoli cells become active at the onset of puberty, and so AMH is there. Inhibin B can also be seen. MRI for olfactory bulbs can also in some cases, but ultimately genetic testing may be required in few cases. Now this is the gonadotropins. As the age advances, we know that gonadotropins after the mini puberty are very, very low, and the gonadotropins start increasing by age of 6 to 8 years in a normal child, and then the physical appearance of puberty that starts at around 9 to 12 years. And this is the baseline line is HH, that is hypo. They're not showing any increase in this thing. And this is a normal child, and this is the gonadotropins, which start increasing much later. And so here you can see from this age that usually the usual age of initiation of puberty till the 14 years, there is some difference between the constitutional delay. So it is said that there are various studies, cutoffs are given differently, but 0.6 is one which is given in many studies, that if the LH concentration is more than 0.6, then probably child is CGDP. And if it is less than 0.6, then probably you are dealing with HH. And this is GnRH stimulation test. You can do it with the native GnRH also. That is, you can give it 100 microgram IV and follow. The peak occurs in between the 60 and 90 minutes, and this is how you can differentiate. In the HH, there is hardly any stimulation. In CDGP, you have stimulation, but the GnRH is not available usually, and we go for the GnRH agonists, and these leuprolide is used in 20 microgram per kilogram body weight. And remember that the peak, it is to be given subcutaneous, and peak occurs at approximately 3 to 4 hours. So you have to take samples only after 3 to 4 hours to see the peak. And this is a diagram showing you the, if you see on that side, this is, you can see the olfactory bulbs and also the sulci related to olfactory. Here you can see that there is no olfactory bulb seen, and the sulci related to olfactory bulb are also not seen. So this is a classical case of Kalman syndrome. Now treatment of CGDP, treatment is masterly inactivity. Reassure the child, reassure the family, and regular follow-up. But some children are psychologically distressed and highly disturbed. In them, we can offer them a sex steroid therapy for a short duration time, and this given for say 6 to 12 months or sometimes 3 months also can initiate puberty, particularly more commonly in boys. In girls, ethinyl estradiol 0.05 microgram per kilogram body weight, or better is the 17 beta estradiol, which can be given 5 microgram per kilogram body weight to be initiated, and dose is adjusted according to height. The chronological age at which we offer them treatment is at 12 years, and we follow till the tenor breast 3 is achieved, and then we stop, and most cases will have spontaneous progression of puberty. In boys, testosterone enanthate, and ciponate, and mixture of testosterone esters. The common preparations we are using is sustanon. You can start with 25 to 100 microgram according to body weight of the patient. Every 4 weeks, we usually give them every month, and this can be continued for 3 to 6 months. And after that, usually these children have initiation of puberty, and which continues. And it gives you a lot of credit, though you have not done anything, but I have families in which father says, डॉक्टर साहब आपने मुझे इंजेक्शन दिया था, मेरी हाइट बड़ी थी, मेरा बच्चा भी ऐसा है, इसको भी दे दो. So this is very common that at least if you want to take credit, you should give it. There is no harm in giving. Now treatment of CHH, congenital hypo, the sex hormone therapy is to be started, is to be initiated, and meant for maintenance and initiation of secondary sexual characters. When fertility is desired, you switch on to gonadotropin injections, and they require gonadotropins for induction of spermatogenesis or ovulation. GnRH pulse therapy is also available, and this can be offered, but it's usually just like insulin pump-like device is needed, but it's usually not available in India. We heard Dr. Rama Walia, she said that for initiation of spermatogenesis, now till now what we were doing was HCG followed by FSH followed by, testosterone followed by HCG followed by FSH. But it usually will take some 2-3 years for initiation of spermatogenesis. Dr. Rama Walia in her oration said that we are using all the three drugs simultaneously, and we could achieve the spermatogenesis at the end of 1 to 1.5 years also. So you can start testosterone to produce secondary sexual character, simultaneously start gonadotropins to stimulate testicular volume as well as spermatogenesis. So this is some summary of what I said, that there's a natural history, there's spontaneous resolution in CGDP and usually requires treatment in HH. Final height is you can achieve by giving treatment in HH, but is normally achieved. Gonadotropin recovery occurs spontaneously in CGDP, and genetic is more involved in HH. Associated findings like synkinesis, anosmia is not seen in CGDP, and you can say that all things we have. So in summary, CGDP and CHH are deceptively similar at the time of adolescence. Prognosis in CGDP is fruitful, a temporary hiccup in the journey towards the adulthood. CHH is, if unrecognized and untreated, can be futile, denying the individual the normal adult life and reproduction. The clinician's role lies in discerning the subtle clues, monitoring the growth, development, and time of that, and properly treat on the individualized basis. For some, delayed bloom of puberty is a season worth waiting. For others, well-timed therapeutic intervention can bring futility to fruition. Thank you very much.
Thank you, Dr. Jindal. We request you to take seat among the audience, and then on the stage, yes, you can come here, and we can take questions after the second speaker has delivered his talk. And ladies and gentlemen, we are very privileged today to have among us very accomplished endocrinologist, Dr. Madhukar Mittal. He is head Department of Medicine, All India Institute, Raebareli, and he also heads the Department of Endocrinology and Metabolism. Widely published, a renowned endocrinologist, and I'll not take much of his time. I straight away ask sir to please start his deliberations.
Thank you to the organizers, and thank you, chairpersons. I'll be talking on pubertal induction and maintenance, specifically in males with IHH, or what is commonly termed as CHH. So I'll start with a case here, 17 years, 4 months male with poor development of secondary sexual characters. Noticed pubic hair since the age of 15, but limited to the base of penis, scant, thin, no axillary hair. Had received 3 months of testosterone enanthate, 100 milligrams, followed by 3 months of 250 milligrams of the same, and then 1 year had discontinued therapy. And when initially presented to us, there was just scant mustache, no beard, with absent body hair, a testicular volume of around 4 to 5 ml, and pubic hair stage 3. These from the case records, you have low testosterone, 25 nanograms per DL, with LH and FSH round 1. And at the end of testosterone therapy, there was a recorded testosterone of 234 nanograms per deciliter. That's when the testosterone therapy was discontinued. So we have a classical case of hypogonadotropic hypogonadism in males, and ruling out the CNS tumors or infiltrative disorders and also systemic chronic diseases, you have the classical scenario of differentiating between CDGP and CHH. And this slide was referred to, especially in males, where you have CDGP constituting around 60% of males presenting at this age group, around 30% of hypogonadotropic hypogonadism, and less than 10% constituting hypergonadotropic hypogonadism and other disorders. So I'll not go into details of differentiating between the two. This has already been discussed. You do some basal testing for LH or inhibin Bs and the dynamic testings, be it GnRH agonist testing, sometimes HCG stimulation, although it's not commonly done now, and you have the newer test of FSH stimulated inhibin B, the data coming from PGI Chandigarh. So if we look at the approach which was discussed, you have 3 to 6 months therapy of testosterone being given as a traditional approach for CDGP. of dosing of 50 to 100 milligrams, and then looking at the response. So it's like a jump start, and if puberty is initiated, that's when you are dealing with CDGP. However, in the case where there is no progression or stalled puberty, that's when you are looking for CHH, and where you go for testosterone therapy, what is known as traditional induction, or you go for the more physiological induction with HCG and recombinant FSH. So the traditional management has been the induction with exogenous testosterone, followed by gonadotropin therapy for fertility. The initial aim is for virilization, and add-on therapy is for fertility as and when desired. Again, here testosterone therapy is increased gradually. You have a background where boys with precocious puberty, where quick progression may be associated with adverse behavioral issues. So testosterone preparations here, enanthate, cypionate in dosing of 25 to 50 milligrams monthly, and then gradual escalation every 6 to 12 months. Alternatives you have of transdermal testosterone, but there is a chance of potential transfer, so less used. So coming back to the case, at 18 years, 9 months with unicoid proportions, TV of 4 to 5 ml. The evaluation here, again, testosterone came down to 14 nanograms per DL with LH of 0.7 and FSH of 2.4. So low LH FSH with testosterone, normal imaging. You have a case of delayed puberty, normosmic CHH, non-syndromic with low bone mass, who had prior received 6 months of testosterone. So considering CDGP, had already received 6 months, but then no progression with low testosterone. So you're dealing with a case of hypogonadotropic hypogonadism with incomplete puberty and no ejaculation. Treatment given here was HCG alone twice a week. So coming to the other part, the physiological pubertal induction, where we try and mimic normal puberty with gonadotropins, and we look at some of the newer evidence and regimens here. So you can use HCG alone, HCG followed by FSH, or FSH followed by HCG. You can even use a combination therapy, and then you have papers of triple therapy as well. So if you're looking at physiological pubertal induction, you have a scenario where the testicular volume is really low, and then you pre-treat with recombinant human FSH, followed by combination therapy, add-on HCG. Or when the testicular volume is reasonably 4 ml or beyond, you're using HCG monotherapy considering cost considerations, and then you add on recombinant human FSH. However, there is enough data now for combination treatment of HCG and recombinant FSH right from the start. GnRH infusion really, it's only in the research settings and not actually used in clinical scenarios. The basis for all this is, if you look at this chart here, so you have in the gray or black, this is what normal pubertal course from infancy, childhood, and to adolescence goes through. You have delayed puberty here, and then you have stalled, absent, or partial puberty with the purple lines. And if you look at the blue line, that's gonadal dysfunction, and you have incomplete activation of the HPG axis, that is the CHH, where the GnRH neurons may be absent or deficient. And this is another important slide where we look at changes in anatomical aspects and the circulating aspects, levels of the sex hormones. And if you look at this slide here, in the early fetal part, it's actually the independent gonadal hormone secretion which sort of drives masculinization in the fetus. And in the latter part of the fetal life, it's the gonadotropin dependent gonadal hormones which sort of take over. And then in the early infancy, that is the mini puberty, it's again there is a mini peak here, gonadotropin dependent here. And then there is a sort of childhood quiescence where the gonadotropins are low, although AMH and inhibin B are still high. But there is now data to show that FSH levels sort of drive almost doubling of testicular volumes from say 1 to 2 ml even during this period of childhood. And then during adolescence and puberty, there is again onset of puberty with dramatic increase in testicular size, and this is again gonadotropin driven. So this is a meta-analysis where they compared or looked at data of HCG alone and a combination of HCG plus FSH. So dual combination therapy. And what was seen was that this combination appeared to induce a greater increase in average testicular volumes than when giving HCG alone or later adding on a combination therapy. Penile length was equivalent between the two similar groups of HCG alone or the combination therapy here. Also, the endpoint when we are looking for pooled proportion of patients achieving spermatogenesis, and this was using a random effect model here. So when we looked at data for HCG alone, this was 40%, as compared to a combination therapy for HCG and FSH, where this was around 86%. So that's the difference seen in this combination therapy of HCG plus FSH. So convincing evidence regarding efficacy of gonadotropins for attainment of pubertal outcomes and spermatogenesis was shown in this meta-analysis. Although there was substantial heterogeneity with regards to the treatment choice. So whether you used initial followed by combinations, that was not clearly, that was around 76%. This is paper from PGI Chandigarh, Dr. Amawalia's group of triple therapy where they compared low dose HCG, so around 500 units thrice per week, so 1500 units, FSH and testosterone 100 milligrams biweekly, as compared to conventional therapy with high HCG dose and similar FSH dosing. And they had similar outcomes for spermatogenesis, although this was much earlier as compared to Western literature, so 12 to 15 months as compared to 2 to 3 years in the previous data. Coming back again to the case here, this was response to HCG, where over a period of 6 to 7 months, pubic hair staging moved to 4, testicular volume 8 to 10 ml, and testosterone levels achieved were 640 nanograms per deciliter, and patient was able to ejaculate with the total sperm count of around 2 million per ejaculate. Some images, some growth of pubic and facial hair with increase in testicular volume. So with regards to choice of therapy, we are moving from testosterone to gonadotropin therapy, wide range of pubertal induction regimens, no clear evidence that one is superior to another. Choice is many times based on preferences of the patient, cost, availability, and fertility considerations, especially with regards to what is the initial size of testicular volume we are dealing with. So we may want to start with earlier FSH or pre-treatment followed by combination therapy, or if we have a good enough testicular size, go for HCG to reduce the cost and then add on FSH, or we can go for combination therapy right from the start. A word about timing of therapy, and this is important. So usually when we are thinking of CDGP, we are delaying actually induction therapy, pubertal induction, but data from LCMS has shown that testosterone starts to increase a year before the appearance of pubic hair, so around 11 and a half years of age on an average, as compared to when this was measured by RIA, where the median onset was around 12.5 years. So the ideal time for pubertal induction would be around 11 to 12 years. So if we have clinical pointers to say like midline facial defects, cryptorchidism, micropenis, or we are moving towards CHH in our diagnosis, 11 to 12 years would be the ideal age to start off pubertal induction earlier. Otherwise, we may want to delay it. Monitoring, we obviously monitor by clinical parameters like testicular volume, pubic hair staging, erections, secondary sexual characteristics at each visit. Biochemically, we are looking at serum testosterone 6 to 12 weekly. FSH and inhibin B we may want to check depending on the regimen we are using. Radiologically, actually, we are not using. It's only used when there is some discrepancy in what clinically we are measuring and the biochemical parameters. Transitioning and maintenance therapy. So we switch to testosterone therapy once pubertal induction with gonadotropin therapy is complete. So rapid initiation of spermatogenesis is reported, as shown in the previous data, with repeat gonadotropin therapy once fertility is desired. And semen analysis should be performed prior to switching. So the advantage here is of identifying poor responders to gonadotropins early, and which may be predictive of poor sperm response in adulthood. And we can offer our patients with severe oligospermia sperm cryopreservation. So that's an advantage of this. In maintenance, we are all aware, and I'll not go into details, of adult dosing of therapy. So we are using testosterone enanthate every 2 to 4 weeks, or the longer forms of undeconate here every 3 months. Gel is sometimes used. Besides libido and sexual function, the aim also is to maintain lean muscle mass, bone health, and good hematopoiesis in these males. We add on fertility regimens in these patients. So HCG followed by FSH, or a combination therapy, depending on individual choices here and individual scenarios. The factors affecting fertility predominantly is not genetics here, but it's actually cryptorchidism, dysgenetic testis, or delay in surgery for cryptorchidism, testicular volumes, really low testicular volumes, and maybe there is some data for inhibin B also. I'll also touch upon specific aspects. Please do not forget to identify complex syndromes in CHH like Charge syndrome or septo-optic dysplasia, where multipituitary hormone deficiencies also need to be managed. I touched upon this, the non-reproductive phenotypes, where you may want to intervene early at 11 to 12 years of age for pubertal induction. Another interesting aspect to look at is remission or reversal in these patients of CHH. We all know this NEGM paper of 2007. So 10 to 20% of patients may have reversal in CHH, including patients of Kalman syndrome. No clear-cut factors, but sort of may represent mild end of the clinical spectrum or plasticity of GnRH neuronal systems. Especially when we are using gonadotropins, we are sort of normalizing a sex steroid milieu, and these sort of are critical. So the genes involved are sex steroid responsive here, and some of them may reverse. Also, it's important to note that re-reversal is also known. So some patients experience relapse to a state of GnRH deficiency here. So around 50 of 50 patients reported reversal in this series, and the reversals occurred both in men with absent and in men with partial puberty, suggesting that previous endogenous GnRH secretion was not predictive of a future reversal. So how to assess for remission for reversal? Criteria is a testosterone level of more than 270 nanograms per deciliter after discontinuation of hormonal therapy, and this would be after a washout period of around 6 to 8 weeks for injectable testosterone or HCG, or more than 4 weeks for transdermal testosterone. Induction of mini puberty here. I'll just take a few slides here. Now we are talking of induction of mini puberty, where treatment with FSH stimulates proliferation of immature Sertoli cells and spermatogonia in CHH in the stage of infancy, the mini puberty phase. And there is no fear, because the androgen receptor during the first 5 years of life on the Sertoli cells is not expressed. So that's taken care of. So when there are red flags, similar red flags of micropenis, undescended testis, along with the other midline defects and so on, that's when you intervene. There are case studies, case series, which have shown that there is increased testicular volume and increased penile length along with inhibin B when treated during the mini puberty phase. So this is just this year JCM review and meta-analysis, which has shown that inducing mini puberty in these patients led to a significant increase in penile length, inhibin B and also led to partial or full testicular descent in around 70% of these patients. So combined gonadotropin therapy in infancy would basically lead to an increase in testicular volume of 2 to 5-fold. Testicular descent in various series has been shown to 60 to 100%, increased in penile length, and increased serum inhibin B. So what has been tried is basically to induce mini puberty in patients who have absent mini puberty in these infants. So I'll just summarize here as to the approach. So when we have a patient of hypogonadotropic hypogonadism, we want to rule out chronic systemic diseases, other pituitary disorders, functional scenarios like stress or excessive exercise. We are dealing with delayed puberty with isolated hypogonadotropic hypogonadism. Look at clinical factors like midline defects, non-gonadal pointers, really low testicular volume. If you are actually dealing with or you have confusion, please wait for constitutional delay of growth puberty. You may give a jump start with 3 to 6 months of testosterone therapy. Otherwise, you go for treatment or induction for CHH. And again, you are looking for response. So in CDGP, it will go for natural progression, while in case of CHH, you would want to continue till full induction of puberty. Some challenges remain in CHH management, as we have discussed during this talk. So detection and diagnosis, especially differentiation with CDGP, timing of initiation of treatment, early 11 to 12 years versus 14 to 18 years of late adolescence therapy. Nowadays, induction of mini puberty is also being tried, neonatal gonadotropin therapy. What we are trying to do is mimicking physiological puberty with gradual dose escalation. Transitioning to adult care is important. Adherence and close follow-up needs to be maintained. Also, it's important, it's our responsibility to inform our patients that reversal may happen in 10 to 30% of these patients, and we need to look for it. Psychological and peer support needs to be provided, and the ultimate goal of fertility is what we are looking at in these male patients. Thank you.
Thank you, Dr. Mittal. You can come and join us. So I open the the session to questions from the audience. So anyone has any questions, you can just come forward.
So any questions from the audience? So let me state the stage, sir. So my question is, the residents often feel it uncomfortable when telling the time to do the leuprolide or tryptophan stimulation test. So some says it is after 1 hour, some says it's after 3 hours, some says it's after 4 hours. So what do you recommend?
See, when you are using GnRH, the native preparation, GnRH, human GnRH-like preparation, then it is to be given IV. It's given in 100 microgram, and then you take samples at 30, 60, 90, and 120 minutes. And this IV preparations given is producing a peak at around 60 to 90 minutes. Okay, so ideally you should take all the samples, but if you are monetarily constrained, you can take a sample at 60 minutes. That will usually differentiate. But when you are using analog, which is to be given subcutaneous, then the peak occurs at around 3 hours to 4 hours, because you have given it subcutaneous and it's a depot preparation. Okay, so this is the difference between these two curves.
So sir, it is okay if we take either 3 or 4 hours?
Yeah.
So any questions from the house?
What is the FSH stimulated inhibin B? Can you differentiate between the two? What is your experience?
See, inhibin B as well as AMH, they are being produced by Sertoli cells. If there are functional Sertoli cells which are about to mature, then they are likely to be on the higher side in CDGP. As compared to when axis is completely dormant, they will be very low. We usually normally do not go for these tests. We are satisfied with GnRH establishing test.
I have one question to Dr. Madhukar. So the administration, coming to the practical administration of the HCG and FSH, what I found was that, HCG, even if we ask the patients to take 2000 IU 3 times a week, there are no multi-dose pens available. There is a single multi-dose pen available for FSH, which is convenient. And patients have to use them for 6 months to 1.5 years. So one of my patients used it for 1.5 years with successful, spermatogenesis and pregnancy. The main issue is breaking the vial and taking it the form. I mean, do you have, in your practice, do you use any particular preparation or any tips and tricks you have?
So India is a place where you have all sorts of things where even the higher dosages can be reduced because of cost considerations are there. But yes, it's a challenge because you don't have multi-use injections or injectable pens which are there as we have for GLP-1s where it is used. So ultimately what we have is using the vial and then dividing the dosages. So many a times what you have, especially in the market, is preparations of 2,000 or 5,000 units is what is available. So especially when, as for pubertal induction, when we want to use low dosages, that becomes the biggest challenge as to storing the vials properly and then using the same vials for multi-dosing. So that I agree that challenge remains in practical aspects.
There is a multi-dose pen available which is used in fertility practice. I use that now for patients. You can use it 3 times a week actually. So it's a pen device which you can dose several times. So such a convenient pen will really help in, because it's a small subpopulation, hypo, and especially men, where it's used for a long time. So it's ignored completely. The pharma is not concentrating. I think there are colleagues from pharma here. If they are hearing us, if they can prepare give us a same HCG, if it can be given in a pen like what you get in GLP-1, it will be a huge convenience.
Excellent talk, Madhukar. That's a challenging situation to replace HCG and FSH in a situation where either IHH or even a patient who has hypopituitarism. So at what stage you did tell us about what are the situations where the likelihood of attaining fertility, the prognosis is poor, like one of them being the small testicular size. So at what stage of treatment do you decide that, okay, this is not going to work any longer? Cost is a huge constraint, and the patients keep asking, or kitne din lena hai? And there are people who are actually selling off things to take these drugs, and so at what point do you decide, okay, now enough is enough, go for something else?
So one thing, the good thing is we are not looking at libido or sexual function initially in the pubertal induction phase. What we are looking for is maintenance of testosterone levels, our clinical improvement parameters, and spermatogenesis. So data from the West has shown around 2 to 3 years. And there is data from India where combination therapy has been used, even triple therapy. 12 to 15 years is the 12 to 15 months is the median time for spermatogenesis achieved in these studies. So you can individualize between 1 to 3 years for your patients at the start. Patients who do not achieve good spermatogenesis during this period, now you have options for sperm cryopreservation. But that is again in India, very few centers it is available. So 1 to 3 years is what we are looking at as an option there. Yes, patients do come with a challenge because testosterone sort of gives that kick of libido, which is not so well achieved with gonadotropin. So we need to explain our patients that initially what we are looking at is good increase in testicular size, sort of FSH helps there as compared to testosterone therapy. And later on, we can just switch. Once spermatogenesis is achieved, that's when we can switch to testosterone therapy.
Sir, any experience for the mini-puberty induction in your practice?
Not at all. Not at all.
And doses, any same?
So I haven't used anything for mini-puberty. The challenge remains is it's actually the pediatricians or the neonatologists who deal with it. this is actually just in research studies. I'm not sure even in India where people have actually used it or where they actually refer to endocrinologists to actually deal with this. So I have no clinical experience with
andrology
this.
journals. So they recommend andrology journals.
Sir is referring to andrology journals.
Yes.
So they say something age 10 years, if value not achieve 0.07 testosterone in nanomole per liter, then they start 1000 unit HCG like recommendation andrology. So
Yes, 0.7. So that's what testosterone cutoffs basal. And even that has been published in Dr. Ramavalia's paper also, that 0.71 is there. But it's only in research settings. Clinical experience, if anybody has, can share for mini puberty induction. But I'm not too sure if anybody has done that.
In the same line, if a patient whom we have diagnosed in mini puberty to have, supposedly to have IHH and we are going to start therapy. So would it be prudent to start with HCG or we should go for recombinant therapy?
Mini puberty?
For mini puberty, for further, if the parents are after the due discussion, they want to have their child's fertility to be established, and they are reasonably affluent and they are well-to-do. So what to do?
So you're talking of adolescents?
Yes, sir. They're in the infancy only.
In the infancy only. So in infancy, as I showed in that slide, where in the latter half of fetal life, so in the initial part of fetal life, it's gonadotropin independent testosterone secretion, which sort of leads masculinization. But in the second half of fetal life, it's actually gonadotropin dependent, and combination therapy of LH, HCG and FSH, that's what's been tried predominantly to try and see for inducing mini puberty. This leads to increase in inhibin B, increase in penile length, increase in testicular volume, and also future increased chances of spermatogenesis. So if cost is not an issue, combination therapy, that's what we are looking at. Because it's a short window, mini puberty is a short window where we want to give therapy.
Try for that, sir.
Yes.
Because in India we have certain legal issues and all those things. So given those things, that whether to try FSH or not, like that only.
Yes, absolutely. So even for adults, I'm sure it's off-label therapy. It's not like in adolescents. So it's not like DCGI has made it an approved therapy. It's off-label therapy. So it's the same which applies for mini puberty also.
Thank you. So any questions from the house? I think our discussion has been a fruitful one, sir. So, thank you, sir. Thank you, the respected chairpersons and the excellent speakers, for having lucidly explaining to all the things to us and having a very fruitful discussion. And that brings us to the sad reality of life, that every good thing has to come to an end. And that's why we have to conclude this session at this hall, Becharam Sadhukhan Hall, for today. However, our academic extravaganza is still ongoing at Hall A, where I would like to ask all of you to kindly gather in Hall A for the next academic sessions as well as the valedictory. Thank you. Thank you all. And you have been a very good audience to all of us. Thank you us for giving the opportunity. Thank you.